Hello and welcome. Thank you for joining us for this 2022 UCSF World TB Day Symposium. My name is Payam Nahid. I'm a professor of medicine in the Division of Pulmonary and Critical Care Medicine at San Francisco General Hospital, UCSF. I also serve as director of the UCSF Center for Tuberculosis. My co-host is Lisa Chen. Lisa, are you here?
Yes, hi, thank you. And thank you everyone for coming. I'm also at the University of California, San Francisco, and a professor in pulmonary and critical care medicine, and I run the Curry International TB Center. So thanks everyone for coming. Payam.
Yes, thank you, Lisa. On the 24th of March each year, the world commemorates the day in 1882 when Dr. Robert Koch announced to the Berlin Physiological Society that he had discovered the cause of TB, 3 weeks later publishing an article entitled The Etiology of Tuberculosis. We are delighted that for 4 years now, the UCSF World TB Day Symposium is linked with and live streamed in partnership with our friends and colleagues at the University College London and the London School of Hygiene Tropical Medicine in the UK. Today, we have a terrific program of speakers, including a live session with London on innovative trial designs in TB. Importantly, we will open with a keynote dedicated wholly to learning from TB survivors and their experiences with TB care. For centuries, TB has remained the largest cause of adult and children's deaths from any single infectious disease, surpassed only recently by the COVID-19 pandemic. Compounding this devastating fact, when TB and war overlap, their partnership spreads disease, heightens misery, worsens suffering, and intensifies mortality. TB, not surprisingly, is one of the most frequent and deadly diseases to complicate the circumstances of warfare. In a special series entitled Tuberculosis and War, co-edited by our own late Professor John Murray and Professor Robert Lodenkemper, they note that wars with their human butchery and systematic destruction hasten the spread of TB and its mortality. Risk factors for TB in wartime include malnutrition, starvation, weakened host immune defenses. They note overcrowding at the front, underground shelters, prisoners of war quarters, all contribute to the transmission of the tubercle bacilli. And disruption of medical and public health services compound the ability to care for these patients. Attacks on hospitals and healthcare workers, strikes that are claiming the lives of civilians, including children, a humanitarian crisis with vast numbers forced to flee their homes, and a disregard for human life. These are the scenes that we are witnessing in the Ukraine, where a brutal invasion has transfixed the world. But these scenes are also present in Ethiopia, Myanmar, Yemen, Syria, among many places. People are suffering from war and the diseases that follow. Professors Murray and Lodenkemper noted that in the midst of all the chaos and destruction during the several months terminating World War II in 1945, the first two effective drugs for the treatment of TB were discovered, PAS and streptomycin. As I said last year in our World TB Day event, in order to eliminate TB, especially in the face of so many overlapping struggles and unprecedented challenges, we must and will continue to dare mighty things. I wish you all the best World TB Day. I hope you enjoy the program today with London. And I would like to hand the session over to my colleague, Professor Eric Goosby, to moderate the keynote on my TB story. Dr. Goosby is an internationally recognized expert on infectious disease with a specialty in HIV/AIDS clinical care research and policy. During the Clinton administration, Dr. Goosby was founding director of the Ryan White Care Act, the largest federally funded HIV/AIDS program in the US. He went on to become the interim director of the White House's Office of National AIDS Policy. In the Obama administration, Dr. Goosby was appointed ambassador at large and implemented the US President's Emergency Plan for AIDS Relief, PEPFAR. After serving as US Global AIDS Coordinator, he was appointed by the UN Secretary General as the Special Envoy on Tuberculosis in 2015, where he focused on the first ever UN high-level meeting on TB in 2019. And most recently, Dr. Goosby served as member of the Biden-Harris Transition COVID-19 Advisory Board. And he is currently a professor of medicine at UCSF School of Medicine and leads the Center for Global Health Delivery, Diplomacy, Economics in the Institute of Global Health Sciences. Eric, thank you very much for joining us today and moderating this session.
Thanks, Payam. It's a real pleasure and an honor to convene this day with everyone. I think the extraordinary period we've lived through with COVID, the challenges that it's created for all delivery systems all over the planet, tuberculosis systems were by no means spared. The hesitation to present yourself, to get diagnosed and treated, to stay in that relationship over time, and to confirm sterilization has been always a challenge, but I think this time added the orchestration and chaos that COVID presented to each one of us in our respective clinical settings. All the more reason for us to take pause, as Payam just said, and look at, again, the challenges that tuberculosis presents to us. Always a tension between implementation efforts, opportunities, versus the kind of list of diagnostics, therapeutics, efficacy, safety, and our ability to keep patients' and families' attention long enough for them to realize the benefits of the diagnostic and treatment interventions. To that end, today's discussion appropriately begins with the target of all of this effort. The point of all of this effort is to diagnose and treat disease in people so they can benefit from the science we already know, and also for us to better understand issues of access and retention that tuberculosis has always challenged delivery systems since it first presented. So it is a pleasure to introduce Congressman Bera, who's a member of the House Foreign Affairs Committee, where he serves as chairman of the subcommittee on Asia, Pacifica, the Pacific and Central Asia, and non-proliferation. He's also a senior member of the House Committee on Science, Space, and Technology. As a medical doctor and former public health official, Congressman Bera is a strong champion of American leadership in global health. He's a co-chair of the Congressional Tuberculosis Elimination Caucus, which works to expand federal efforts to address the global TB pandemic. We'll now benefit from a tape recording.
Hi, I'm Congressman Ami Bera. For purposes of these remarks, I'll be Dr. Ami Bera. And again, I want to express my appreciation to the University of California, San Francisco, and all the academic health centers for the great work that you do finding cures for tuberculosis and helping work towards elimination of tuberculosis. On this World TB Day, let's continue to understand and recognize the impact that tuberculosis has, not just here in the United States, but all across the world, as hundreds of thousands continue to needlessly die from tuberculosis every year. It's easy to forget in the midst of the COVID-19 pandemic, but we've got to continue to, not just defeat COVID, but also continue to work together, invest in the research, come up with the therapeutics, as well as hopefully vaccines that will help us one day eliminate tuberculosis. It was my great pleasure and honor to co-chair the House Tuberculosis Caucus, and I'd like to take a moment to recognize the passing of my colleague, Representative Don Young, who was my co-chair of the Tuberculosis Caucus and my co-sponsor when we introduced the Elimination of Tuberculosis Act of 2021. Losing a champion like Don Young is going to be very difficult to replace, but again, in his memory, we should double our efforts to eliminate tuberculosis here domestically, but also internationally. Again, on this World TB Day, thank you to all the academics, all the researchers, and all the doctors, nurses, and healthcare workers here in the United States and around the world that are helping keep us safe, helping address various pathogens like tuberculosis as well as COVID. And let's go out there, let's be kinder, let's be gentler, and let's be a world that works on this together. Be well, be safe, and be kind.
Well, thank you, Congressman, for those comments. I think we'll all take those to heart. I now wanted to turn to Phumeza Tsile, who's a TB activist, a student at the University of Cape Town, and an advocacy officer at TB Proof. In 2010, she was diagnosed with drug-sensitive tuberculosis while all along having multi-drug resistant XDR TB. She went through a grueling treatment of MDR TB that left her deaf in both ears. And she's going to relate some of her challenges, concerns, and reflections on the course that she took. Please, Phume.
Thank you, Dr. Eric. So as you said, yes, I am Phumeza Tsile. I am based in Cape Town in South Africa. So at the time, it was in 2010, and I was a first-year student at university. I saw that I was not well. Well, I did not have the obvious TB symptoms like sweating at night or coughing, just that I was losing weight drastically. So obviously, because I was not well, I went to the private doctor, of which they check for all common diseases, and they all came back negative, which is including HIV. So at this point, because he saw I was not well, he said that because they do not check TB in the private sector, I need to go to the public clinic to get tested there for TB, of which I went to the public clinic. I coughed out, and I had to wait at the time for 3 weeks to get the results. And the machine called to an expert was not available. So they called after 3 weeks to go back to the clinic. I went to the clinic, and they told me that they did not find nothing wrong with me. My sputum came back negative, so I did not have TB. But again, because they can't send me home because they can see that I'm not well. One doctor said I must do a chest X-ray, and then from the chest X-ray, they diagnosed me with TB. I remember them saying that this is bad. So I was given, I'll call them normal TB drugs. They were easy to take, 3 tablets, but I was not getting better at all. I went back to the clinic again to cough out. Usually it was after a month or so. I did cough out. I had to wait again for 3 weeks, getting sicker by the day. I had to discontinue my studies at the time. And they told me now that I must come back. The results came back that I have MDR TB. So obviously I was young. I had no idea what they were talking about. So I found myself Googling what is MDR TB. And there were all those disturbing photos of people assumed to be sick of MDR TB. So anyway, I was given that day about 25 tablets, and there was also an injection. So I thought this was a joke because there's no way someone can take 25 tablets a day, every day for 2 years, and an injection every day for 6 months. I mean, they ran out of places to inject me, and I was vomiting every day because of the toxicity of the MDR TB drugs. But at this point, I was at the hospital, Kongressional hospital, and I was getting better, and I was responding to these TB drugs, the MDR TB drugs. And then I woke up and, went to the bathroom. I flushed, and no, there was no sound of what was happening around me. So I went to the nurse at our ward, and then I told her what was happening. But then she was speaking to me. At this point, I could not make out what she was saying because I could not hear. She ran back, and then she came again with a pen and paper, and then she wrote that I must go to the audio department at Brooklyn Chest Hospital. So the audiologist did all these tests. I was wearing these huge headphones, and when they were playing some sound, I could hear some, I could not hear some. And then after that, they wrote on my folder, which is my MDR TB folder, that I was deaf, and then it was in capital letter DEF in red cookie pen. And then they wrote down that I must go to my doctor, the MDR TB ward. So now the conversations were changing for me because now I was the one doing the talking, and then they were to be the one doing the writing. So the doctor explained that first thing she wrote is that she was very sorry that I got deaf because of the injection I was getting. and that there's nothing that they can do and that it is not reversible. But then she said that I need to move now. No, I'm no longer MDR. They said I was pre-XDR, which is pre-extensively resistant TB. So I was moved to another ward still at Proclentius Hospital. And then they had to check me as if I was a first-time patient. So they saw something building up in my lungs. They were not sure what this was. They assumed cancer, they assumed tumor. But then I was referred to Fortescue Hospital here in Cape Town, of which it was just some liquid that was building up. And while they were doing the surgery, because I was fragile, I was small, they broke one of my ribs and they punctured me. So anyway, I got better. I was sent back to the TB hospital, and it was like almost a year. And then I was eventually discharged because I was well. And then they told me that I'll be taking my medication at the clinic, and they were sure that I was going to be okay. But I think 9 months while I was taking my monthly medication at the clinic, meaning I was home, I was discharged, I was called again. There, this paper written out that the pre-XDR TB drugs that I was taking had stopped working, and that I had 20% chance of surviving this XDR TB now, and that they were saying many things that some of them I prefer to forget. But anyway, they gave me a choice. There was this organization called Doctors Without Borders, which is MSF, Doctors Without Borders. And they told me that there's a drug, but this drug is not approved yet for TB, but they are willing to try it on me. And then they gave me this form to sign. I mean, I knew I had no choice. So I was like, okay, I'll take this drug and see how it goes. But then with this drug, there were also ups and downs. There was a point where they had to stop it because it was too strong for me. They had to cut it in half. But then they actually gave me another chance whether I should stop this drug and I would die slowly, or I should continue this drug. And then they said that if I continue this drug, it should be a miracle if I survive XDR TB. Then obviously I opted to continue with this drug, and for some reason it worked, and I didn't have those side effects anymore. And after 3 years now, in 8 months, which was in 2013, I actually got cured of XDR TB. They had this huge celebration because for them this was not possible. But remember, at the time I was a first year student, so that meant that after I got cured, I wanted to go back to university, but I couldn't because I lost my hearing due to the injectable I was getting at the time. So I was checking how to get your hearing back, stuff like that, and I came across cochlear implants, and the price was like $40,000 US. That's like $500,000 in my currency. Obviously, I didn't have that type of money. And because I was blogging about my story, journalists were interested in my story. We were able to raise that money in like a month. It was around Christmas. We were able to get the money like a month. So I got my hearing back through the cochlear implants, and I was able to go back to university, and I graduated at UCT, University of Cape Town, and I have a social science degree. So I have this question that's asking what are doctors are not doing well or are doing well. Well, for one, you should stop treating TB patient as if they are objects. You should put the patient at the center, whereby it's decision-making, whereby you need to inform them about the new drug, whereby you need to tell them that something is not working. Because I noticed at my time, I wasn't given a choice whether I want to take this injectable tablet. I wasn't given any information about the drugs I was taking. I wish I knew that I should expect maybe blindness from this medication called endambutal that actually caused irreversible blindness and injection. I don't think I would have taken something I knew that would have devastating sort of like life impact at the end. So doctors should always put the patient at the center, should always be sort of like be in control of their, I mean, it's my health. I knew it was my health, but I wish I knew the things I should expect because I am this toxic medication that is already making me sick, but I'm already sick. So yes, that is my TB story. Thank you.
So thank you so much for that clarity. I think that the urgency of understanding what it means to put patients at the center of the delivery system's attempt to identify, enter, and retain you in care really came through very clearly, and thank you for that. We can unpack that a little bit more in the discussion. I wanted to turn to Gloria Carubo. Gloria Carubo is an advocate for human rights, especially health. She is passionate about community engagement and leveraging on the power of communities, understanding the importance of that in holding governments and institutions accountable. She has been focused on innovation in social change and technology, and she has served in various youth representative roles and is current member of the Global TB Community Advisory Board, TB CAB. So thank you so much. Please go ahead.
Thank you so much. I'll be sharing my slides.
You're good. You're good.
So thank you so much. So I will start with a very short story. Mine is the story of a young lady who has just finished college and is ready to take on life and live the best of her ability, you know, where we have freedom and experience the world as it should be. A few months later, she's a bit sick and has to go to the hospital. And in the process of diagnosis, she's diagnosed with malaria, treated. She does not improve. After a while, she's treated for pneumonia. It doesn't improve. So it takes a bit of pushing for her to get an extensive look on what could be the problem, what is the problem that may be happening with her, what's happening, so that we know why is the young lady not doing well in terms of health. So this young lady again has to stop working because, of course, you're not well, so you have to stop working and go back home for your parents to take care of you and be able to progress well and take your medication, and as you try to figure out what's happening. So the lady finally gets diagnosed with TB, gets on treatment, and is able to get well. So that's the story of Gloria. And between Gloria and Fumeza, I'm going to borrow a few experiences that I'll be sharing with us today on experiences. So one of the experiences that people and TB patients go through is diagnosis. So the cost of one to be diagnosed has always been high. The cost in terms of money, the cost in terms of time and resources that you take to finally get your TB diagnosis as a patient takes a while and takes a lot of resources from you. So that's what's lacking. In terms of health, education, and literacy, in most of our communities, you're not speaking about issues of TB. TB is a foreign term. It's a term that is spoken at Ministry of Health and other higher levels. So how then do we bring down the conversation at the community level? In terms of treatment, when you're starting treatment, ideally treatments sound like a very long journey. So then you're scared, you're probably a young child who's trying to understand what's happening. There are a few side effects here and there. You're not able to provide, probably you're not from a stable family, you're not able to provide for yourself in terms of nutrition. And then follow-up. So once you're diagnosed and you've been given medication, continuous follow-up from your healthcare provider, continuous services, and support from the health system and facilities. That's a bit lacking. And then issues of stigma and discrimination. I remember when I was told I had TB, the first thing that happened to me, I cried. I was so scared that I had to cry. I was scared for two things. One, I didn't know what was going to happen to me. And the other thing, I didn't know how the society was going to treat me, knowing that I had tuberculosis. So stigma and discrimination is one of the experiences that people with TB experience. So then what can we do differently? And I'll start with TB doctors. So TB doctors have a lot of information and materials that can be used to inform us and let us know what is happening in the TB world. But this information has not been broken down to a level that someone from the community, someone who needs this information can understand. So as a TB doctor, a responsibility will be one to package the information, and once you are sharing the information, package it in a way that the person you're telling is able to understand and is able to relate to the conversation that you're having. The other one is on option and accessibility. We, as TB, we are making a lot of progress, but this is not reflecting in our response. So are people aware of these options? Are people aware of where they can access some of these services, where they can access things like treatment prevention? Are they aware of all these resources and things that we've made progress and are very proud of? So do we have this information currently accessible and available to the community? Utilizing resources that we have a lot of diverse resources that can help us in terms of diagnosis, in terms of treatment. Are we making use of them? Because you look at where you're getting, the doctor is looking just at your signs and symptoms, and they're like, no, you don't have TB, but you have an gene expert machine. Why aren't you using that as an available resources for you to be able to make a conclusive observation and advise a patient on what they need to do? And then in terms of scientists, the call is to, one, break down the jargon. There's a lot of good things happening that when you hear about it, you have to sit down and read about it, and it takes quite a while for you to understand it. So break down the jargon to a point where community members and TB patients are able to understand what we're talking about. We're talking about issues of the progress we've made in types of pipelines, in terms of treatment, in terms of prevention, so what we have available, and breaking this down so that people are aware of what we have and are able to seek for these innovations that are available. And then, and especially for children, having innovation and things that work for the different diverse populations. So if you're dealing with children, how do you do diagnosis for children? So for children, we know very well that probably you can't get a sputum from a child. So then how do we use the available, and how do we make sure that what we have, we're always working to improve them as scientists, to make sure that they're able to use improved and innovations that work for them. So gaps. One of the gaps that I think I have mentioned before is one on information and updates. We have a lot of resources, we have a lot of materials that we can use to inform people and educate about tuberculosis, but we're not using them. How then do we make sure that people are aware of these resources and this information? In terms of investments, we look at the investment that have been made towards TB. They are not sufficient. So then how do we invest more in terms of our response to TB? How do we make sure that we are not just investing on money, we're investing in information, we're investing in our communities to be able to respond very well? Which brings me to my last point on community engagement. So involving communities at all levels of our engagement. So we are doing pipelines, we're developing guidelines. How do we involve communities so that they're aware of what's happening at global, national, regional level, and they're able to utilize these things? Thank you so much.
So much for that thoughtful review of opportunities in front of us, that some have been identified and others have been identified but not responded to. So that challenge coming from you, Ms. Karubo, is very appropriate. So thank you for that. Our last kind of witness advocate is Rhea Lobo. Rhea Lobo is an award-winning filmmaker with a background in health journalism. As an extrapulmonary TB survivor, she is a strong TB advocate and founded a network of women TB survivors in India. Rhea is a member of the Stop TB Working Group on New Vaccines and the task force developing the global plan to end TB by 2030. So good to see you. Thank you so much.
Thank you, Eric, and I'm so happy to be here. Firstly, I want to thank the team. I think this is a fantastic panel, and I'm really glad to be part of it. To quickly introduce my own experience with TB, if you think that pulmonary TB got no attention, imagine how much lack of attention extrapulmonary TB has received. So that's exactly the kind of TB that I had. My journey with TB started with an ache on my foot, and it felt a lot like a sprain. And I was sure it was a sprain, so I didn't really go to the doctor until many weeks later. And when I did, the swelling was so bad, the doctor did a scan and said, Rhea, it looks like you have either tuberculosis, cancer, or a regular bacterial infection. So I was shocked when I received this prognosis, and I was like, okay. I mean, it was, he said, we need to operate and we'll do a biopsy and figure this out. I said, okay. And I thought it was pretty straightforward. I've not really had a surgery before this, but, I've not had a biopsy before. So this was going to be an interesting experience. And so I did. I went ahead with the surgery. And after the surgery, my surgeon came up to me and said, so Rhea, what we've done is we've taken this tissue from your bone, we've torn it in half, and we've sent it to 2 labs. The first lab was a private lab, and the other lab was an in-house hospital lab. And I asked him, why did you do this? And he said, because if it's tuberculosis, it's hard to diagnose. And that was my first taste of how messed up the system is. And what happened was the in-house hospital report came back and said that I didn't have TB. I had just a regular bacterial infection. So I was started on regular antibiotics. I was very happy. I'm sorry, it was not the in-house hospital report that said that. It was the private hospital report that said that I had regular TB. That I didn't have TB. So I started regular meds and antibiotics, and that was over. I thought TB was long gone. What happened was about 6 weeks after my diagnosis, I woke up one day and I realized, hey, the doctor said he sent it to 2 labs, and I never got the other lab report. That was the in-house hospital report. So I went back to the doctor and I said, I never saw that report. So I just wanted to confirm that, it's not TB for sure. So, and then he looked through my file and he said, oh, I can't find it. So it was lost somewhere in the hospital system. And finally, after a long day, a duplicate report was issued. And in it, I read that I had TB. So now the dangers of this is so far is I've taken regular antibiotics for 6 weeks. And now I am going to change my antibiotics to TB medicines, TB antibiotics, and I run the risk of getting drug resistant. Okay, so that's my first hurdle. I started taking the TB meds, and a couple of months in, there was some swelling in my neck, and then I went back to the doctor, and the doctor said, okay, we'll do a biopsy there as well. And so this was my second surgery, it came back and it said, okay, they found TB there. Okay, and then after another month, again the other side of my neck started swelling. I have a surgery there as well. So it was 3 surgeries down, and I'm wondering what is going on. And the doctor is like, we're not sure if the medicines are working. It will take you about 8 weeks to 3 months to know if it's working or not. And then I was like, okay. And then what happened, and this was my aha moment, was when I went to so many doctors, because I didn't understand the system. It wasn't like as simple as go to the doctor, take your meds, you're going to be fine. It was just very complicated. So I didn't have faith in what the system was doing to me. So I went to so many doctors, right? And ultimately I went to a government hospital doctor in India, and he said that he looked at my meds and he's like, what are you doing? And I said, what do you mean? And he's like, you've been taking the wrong dosage of medicines this whole time. And with respect to my body weight. And I was like, okay, and why is that so bad? And he said, because you run the risk of getting drug resistant again. Okay, so here I am in a system that is trying to really knock me down, and I somehow miraculously survived, because so my treatment was supposed to be a year, which is typical for bone TB and lymph. I had both bone TB and lymph node TB, but my treatment ended up being 1 year and 8 months, just to make sure that the TB was out of my system. So this was my hellish experience with TB. And in the 21st century, I didn't expect something like this to happen. And I'm sad to say that even all these years later, the situation has not really changed. I run a network where we support people who have TB, and they're facing the same issues over and over again, the same, changing multiple doctors, trying to figure out why the quality of TB care is so poor. I'm so glad that there are so many people tuned in today. So if I were to give a couple of recommendations, this is it. Okay. One is, Pumeza touched upon this, but it is really, really important to put people in the center of the work you do. Okay. When I say that, it's not just something to just say. When I look back, I look at the TB response in totality, right? I heard of this new technology, new adherence that someone has come up with, where you take a pill and then you will know if this person who has TB has taken their medicines or not. And I was like, this is the most ridiculous thing I have ever heard, because you're giving someone with TB, you're showing them how much you don't trust them, rather than investing in a new vaccine, for example, to prevent TB to begin with. We're investing in things to help people, to just show them that we don't trust them, and this treatment is long, so let's just figure out if you're really taking the medicines or not, right? With that, that's what we're telling people who have TB. I mean, this is why we're stuck with a vaccine that is 100 years old, right? We still have super long treatments. Our diagnosis is a mess, and I mean, I dream of the day we have a point of care diagnosis for TB, diagnostic machinery. So it's just a mess. That's the first thing. So put people in the center of whatever you do. The second thing is, I think I am honestly very tired of this current situation in global health, where the global north is dominating the global south. Okay, it's a really messed up situation. I actually I'm in a very unique position. I currently live in Denmark. Okay, and it's an amazing country, and I constantly I hear what happens all around, and suddenly I hear that, for example, there are fantastic initiatives that are happening in the global south, but there's no collaboration at all. I mean, everyone's working in silos. No one's really collaborating. The global north is dictating what the global south should do. When the people are affected, expected to just listen. It's just a mess. And I can test. I mean, I know for a fact we have some brilliant brains in the global south, and it's time that we actually work together than work in silos. And that's a really, really important part of as we work towards NTB initiatives. So that's the second thing. And the last thing I want to say is, I think we're really, really good. We're really, really passionate about the work we do. But I want you to ask yourself this question: are you actually a good advocate? Okay, I think all of us, I mean, I speak for myself as well, we're very good at complaining. I'm very good at saying, oh my God, the whole TB response is terrible, right? But what are we actually doing about it, right? I feel like the lack of monetary investments currently in TB, right? We saw what happened with COVID. It's not like one disease can come and people can all come together and say, okay, we'll tackle it, right? But see, TB is a disease that primarily affects the developing world. And I feel like that's why people don't really pay attention to it, right? So when TB has killed 1.5 million people in 2020 and COVID has killed 1.7 million people, all the money has gone to COVID because it's affected the developed world, right? So it's really important for us as people who work in TB to stand up and choose to be counted. It's really important for us to call up our congressmen and call up, our members of parliament and say, hey, you need to invest in TB. We constantly advocate for a strong global fund, and it's really important. We really need a strong global fund, for us to tackle TB. But you need to also understand that global fund only funds implementation. It does not fund project development. It does product development. It does not fund new diagnostics or new vaccines, or, we need alternative funding mechanisms for these initiatives, right? And it's important for us to be informed of our advocacy and make sure that we get what we want, and just learn more about what we need and just seek those opportunities out. And that's my advice to everyone who's listening in today.
Well, thank you so much. That was clear and concise, and I think challenges all of us to, as all three of you have done, realize that these diagnostic and therapeutic interventions have to reach the individuals who need them, the people with tuberculosis, and those individuals have to understand and willingly remain in care over a period of time that is a challenge for anyone to keep. But you articulate beautifully, all three of you, the fact that these are real life individuals with lives that must be shuffled into the system to allow that individual to benefit from the science that we know. And all of your testimonies are examples of missed opportunities. But what you've all brought forward to me with great clarity are the lines of accountability in your respective settings where you are diagnosed and treated in your homes. Are you holding those who are responsible for healthcare of that population responsible for it? Why are we looking to the global north and talking to the north about solutions that are in front of you in your home country? And I would say you're absolutely right, but I would also say all of us need to think about who are the appropriate individuals, institutions, governments that are responsible to respond to the burden that TB has put on us. COVID has reminded us of the institutional capabilities, but what we haven't seen is a forum or platform where appropriate prioritization and allocation decisions are made in concert with need and in dialogue and awareness of the population that depends on them. So lines of accountability, I think, are what I really hear loudly from all three of you. But do either of you want to comment on that? I know that you all spoke to it. Pume? Pume, did you have any reaction to that you wanted to do? Or Gloria, you guys want to amplify on any of those points?
Sure. So just to respond back, one of the challenges in holding those accountable is lack of information. So we have a bit of information here and there. For you to be able to hold someone to account, you need to have all the facts, you need to have all the information that you need. That's why, we need to have a bit more information flowing down to the communities and communities being able to utilize this information. So what are the facts? What is happening? What do we need? So once you have this information and you're well informed, then you're able to hold, be it your government, be it whoever you need to hold accountable to. Once you have the information, then you're able to hold them to account based on facts and based on the knowledge and information that you have. Thank you.
I think that's very true. Rhea?
Yeah, Eric, just a couple of points here. One is, I think it's important to understand the numbers, right? At the UN high-level meeting that happened in 2018, we asked for a very modest sum for investments in TB. That was $2 billion a year for everything, right? And I mean, with COVID-19, within 11 months, we got over $100 billion in just vaccines and therapeutics. So $2 billion for everything is already a very, very small sum, in my opinion. Okay. On top of that, when we look at the highest amount of money that has actually been raised over the past 3 years was in 2020, where we reached about 915 million, I think, or 35 million. But that the value was less than half, right? And it's just I was asking myself this question, okay, why is that the situation? Like, why have we reached just half? And I feel like there are a couple of things. One is accountability, of course, like you touched upon, and we need to hold governments accountable for the commitments they made and the fact that they have not delivered even before COVID-19 happened, right? They have not delivered. The second thing is we also need to understand that at the end of the day, unless we ourselves sit up and advocate for what we need, right? Nothing is actually going to change. See, there is a very, we all know, for example, and I spoke to this a little bit, but we all know that if we want to fund project the implementation in countries, you go to the Global Fund. But where do you actually go if you want to fund investments in vaccines or diagnostics? Or, do we have a fund of sorts where we can put in money? And I think it's important for us to be imaginative and think out of the box and think of what are the other alternative funding mechanisms that are available for governments to easily sit and invest in. Okay, and I think it's about pitching better, about being better communicators. And I think that's what has been lacking so far in the TB response.
Very good. I think that you all speak to a shared responsibility that begins, I think, appropriately with the community and the people who are suffering from the disease, tuberculosis. That advocacy must be there for other advocacy efforts to get roots and actually result in a change in prioritization by political allocators. That community voice needs to define and protect a platform where a continuous dialogue can emerge and where providers of care, nurses and doctors who play a different role in the response to tuberculosis can add their advocacy voice to it, again, to the same appropriators, those who prioritize allocation decisions. I think we don't see ourselves as civil society and as providers of care as having a utility in that voice. We understand our role in a different context, but I think what I hear from all three of you is it's time for us to understand where our needs and responsibilities overlap with one another, so our voice is the same to advocates and allocators. And I really do think that is a very nice way for you to put it together. Data drives it, but accountability and the ability to have that in a dialogue and not just a point of information that starts and stops, but a continuous dialogue, I think are the ingredients that make it change. So, Fumé, any thoughts on that from your perspective? The confusion around the appropriate drugs, the impact of the side effects from the drugs. There's a role for both the doctors, the nurses, the hospital. There's also a role for peer support and understanding to help disseminate that information. And it may have changed your understanding of what the threats were as you moved into a treatment relationship. Any thoughts on that?
So yes, as I've said, it would have helped that, I mean, having TB, you know, you will probably have TB for 2 years. So that means you'll see the same doctor for a long time. But the problem is that there's always sort of like a fraction. There's this doctor and as a patient, you're sort of like an object. And also there's also stigmatizing language that they use, like for instance, TB suspect, TB defaulter, TB case, like stuff like that. So I'm trying again to go back to this conversation about having the patient at the center of it all, because again, maybe some patients, I don't know now how things are done, whether people are informed before that now they have TB, they should expect this and that. But it would have helped having had to have some sort of like someone, supporter, peer, whatever you might call it, to be through with you on this journey. Someone who's not part of your family, someone who's on the healthcare side of things, so that you can explain to them that, you know what, now I think my skin is changing for one. What is happening? Then they'll be like, oh, look, this is caused by this and that and that. So again, the doctors should always be mindful that you spend a lot of time with this patient. This patient trusts you as their physician. So you should always sort of like have this approach that you are treating this person because they are sick, but then you also want them to get cured. You don't want them to feel ashamed that they have TB. You want to stigmatize them that they have TB. And I think that's the hard thing that TB doctors specifically are sort of like struggling to get, not all obviously, and also with the nurses and the way they speak to people who actually have TB, people who are wearing these N95 masks. Language matters, you know. And I mean, imagine if I'm called something today or I've had bad treatment in the clinic, there's no way I'm going to go back to the clinic in the next morning. So that causes what is usually called loss to follow-up, because people don't want to go back to the place where they were treated like they are not human beings. So we have that problem, and there are obviously many reasons as to why people are lost to follow-up. One of them being what I've just mentioned now, being stigmatized at the place you're supposed to get help in the first place. And also, I mean, you can go on and on. There are many issues out there. I mean, you can mention some things you might have experienced in India. I mean, they are very similar. They were in different parts of the world, but they are very similar, and they sort of like have a bad impact to care, whereby patients are struggling to get cured because of this NPR and XDR TB. So yes.
Are you, Ria, aware of, with your art form, the documentary kind of documenting what and where responses have occurred? I'm curious what you ideally would like to see in that that format. What do you think might help move communities to being stronger in increasing the volume of their voice, getting in front of the more important conversations in their country, understanding where those are? I'm curious what kind of fronts of activity you're thinking about with your work.
Thanks, Eric. Firstly, I think it's the power is really in the people who are affected by TB. And I think it's time that people view them as the experts that they really are. I once went for an event where I was speaking on my experience with TB. And after the event, the organizers came up to me and said, I wish you cried, and I said, why? And then they said, no, because, we wanted a sad story on TB so that the funders can hear and then put one. And I said, really? My worth as an individual just dropped to another level. It doesn't matter who I am outside, these circles. At the end of the day, I am the TB survivor who has to be a particular image, right? And it's pretty pathetic. And I think, firstly, Eric, to answer your questions, we need to join a bunch of bandwagons, right? We need to have TB join, first of all, the COVID-19 bandwagon. Because at the end of the day, especially in developing countries like India, COVID-19 held on to a lot of TB resources to respond to COVID-19, whether it was our doctors, whether it was our diagnostic equipment. We just changed the cartridges and, took care of COVID. TB took a back seat and COVID, of course, took a front seat. But it's just, I think it's important now, that phase has passed, right? It's important to look at TB in relationship with everything else we talk about, whether it's antimicrobial resistance, right? TB is not featured in these conversations. It's not even part of the WHO critical grouping, pathogens grouping, and it's just, I'm wondering why, and they say it's already established a global priority, but we see the numbers, right? No one's really prioritizing TB, so I don't understand the logic in that. The second thing is we need to join conversations, not just on antimicrobial resistance, but also pandemic preparedness, right? The world is talking about, okay, let's prevent future pandemics, but no one is talking about existing pandemics like TB, right? And all this money, like CEPI just got $300 million from the Gates Foundation, but CEPI's agenda is not TB at all. Neither is any pandemic preparedness initiative from the WHO. So it's just, we need to not just talk about TB in silos and say, okay, now everyone give money to TB. We need to talk about everyone give money to TB, but also give money to TB in EMR, also give money to TB in pandemic preparedness. Also give money to TB everywhere so that we can actually get a vaccine finally, a vaccine out there and, shorter. My dream, and that is the day, I hope I could retire, is having at the end of the day, a 3-day treatment for TB. And I know it sounds almost, you can dream on, but it is possible. And I think it's also important to, while we're having these conversations, and initially I know I spoke about the global north and the global south. The key in what I was trying to say is it's important to collaborate, right? It's important to collaborate and understand what is the need and how do we respond to this need. It is important the G20 puts this high up in their agenda, right? Of, okay, we will fund, you want $2 billion, just take it. Like, it's nothing for them, it's just, I think it's important we just join these conversations and ensure we address all these issues that we currently have with TB, because we have issues in every vertical, whether it is drugs, whether it's diagnosis, whether it's vaccines, whether it's treatment literacy, even something as basic as that. And it's important to look at a person who has TB and say, hey, there is value in your experience. Okay, and I'm going to do everything that I can to make this experience better for you. I live in Denmark, Eric. Okay, if there is people-centered care, I'll tell you, I have it here. People really, really value what I feel and what my needs are. And I really want to have that situation everywhere in the world, where we respond to a person's need. And so, for example, even something like DOTS, for example, right? We're trying to get people to say, hey, we will take this pill. Okay, because we're forcing this down someone's throat, literally. Okay, rather than making this about an individual. And do I really want DOTS? Do I really need dots? Because I for one do not want dots. I don't want someone to look at me on a video camera and me taking my medicine every day. I don't want it, and I think it's really, really important to just, focus on putting the limelight on TB in every conversation we have on infectious diseases and lung health.
Let me just violently agree with you. I think you have beautifully articulated the kind of the obvious and the disconnect that is in front of us at the same time. The COVID experience should energize us to understand that this is about a Venn diagram overlapping opportunity. The shared responsibility needs to stay with us. We need to understand that platforms are how we interface with populations, and without a platform interfaced with the population, they are not going to get the educational information or the therapeutic diagnostic intervention that we have available to them. So it all needs to come together. The patient-centered role in how that information moves toward them and through them is something we are better understanding, but have been terrible with generally, but we are aware of the fact that we are bad with it. And I believe there's a growing awareness of the critical role that patient-centered care brings to identifying access and retaining people in care over time. So I really want to thank all of you for your honest depictions of the burdens you carry and your willingness to engage in solving some of the problems that you encountered in your journey as we now try to bring these services to the whole planet. And want to thank you again for your continued focus on this issue. So I will now turn it over to a break, I guess, is what we're looking at here.
Hey, we welcome you all back after that brief break. I wanted to add my sincere thanks to Eric, Ume, Gloria, and Ria for that outstanding session and enlightening discussion, highlighting so many challenges that we have ahead of us in making the care of TB patient-centered and addressing the inequalities that exist, frankly, across the globe, and that contribute to sustaining the TB epidemic. This is now the section by which we join forces with London, and I see my friend Mark. Indeed. Hi, Mark. Welcome. My best to you on the World TB Day. How's your London sessions been going at UCL and London School?
Yeah. Yes, very good, thank you. And as always, a really powerful meeting, reaching out across the world, not only now that we're connecting with you, which is always terrific, but also hearing from people throughout the globe and the work that they're doing. And I'd like to take this opportunity, if I could just have the slide up, maybe, just to outline what we covered during our session. If that's impossible, I'll just talk.
No, would be happy to do that. Let's see if our colleagues can bring that up. Yeah.
Lovely.
Perfect.
Thank you. And this just outlined, this is obviously GMT rather than UCSF timings on the side there. But as you can see, the focus was really trying to understand the whole patient journey. And so we, as I think with you, were lucky enough to have someone speaking about their experience of TB, which is always so incredibly sobering, even if you're treating people with tuberculosis for years and years through lots of different patients. When you hear one person's testimony, it's so powerful. And then followed that up with other discussion about how to perhaps control some of the post-TB consequences. We then shifted gear a bit, 140 years after Koch's first public announcement of the cause of TB, looking at some of the post-genomic work that's been done, and agreed that there's still a lot to do. We were lucky enough to have a presentation on SHINE, which is, as you know, in a very similar way to some of the work that was headed up by UCSF in adults 4 months treatment. So the SHINE was pediatric TB, looking at the shortened treatment regimen in certain selected children, and how that is also turning into WHO practice and guidance. And then our last session was on the impact of COVID-19, which we all know has swept, probably damaged tuberculosis and associated services more than any other area. And there was some good news in all of that, in that some of the novel diagnostics for TB disease do seem to still work well within a COVID saturated environment. So some interesting and important information coming out, as we know that we are now moving into a time where COVID-19 is likely to be endemic, in particular in areas of the world where obviously tuberculosis is also endemic. And here we are in our final session for us, but almost the start of your day. And it's great, as always, to feel a part of this global TB community. So I'd like to hand back to you, Payam, at this point and say thank you for having us.
Pleasure to be a partner with you, Mark, and your colleagues and our friends in London. So we will now move to our first scientific session, Let's Make It Count, and its innovations in patient-centered trials. And this is indeed live with London. So I hand it over to Dr. Angela Crook and Gustavo Velasquez to moderate this session. Thank you.
Great, thanks Payam and Mark. Hello everyone, and I'm very happy to be here co-chairing with Gustavo this first session, joint London UCSF, on Let's Make It Count, innovation in patient-centered trials. So I'm Angela Crook, and I'm a statistician, and I'm the programme lead for respiratory infections trials at the MRC Clinical Trials Unit in London. I'm delighted to introduce the first two speakers for this session. First, a colleague from MRCCTU, Annabelle South, who will be presenting on patient-centred outcome measures and what matters most to patients. Annabelle is part of an international team that have been carrying out qualitative research with drug-resistant TB patients in Georgia, Mongolia and South Africa to better understand their treatment experience, with the ultimate aim of informing what outcome measures should be used in future trials. The second speaker is Dr. Byrne Thomas Nyawanga, who is the Chief Investigator of the TB PRACTECAL trial and the Medical Director for Doctors Without Borders, MSF, in the Netherlands. Dr. Nyawanga will be giving us an overview of the journey of the TB PRACTECAL trial, taking us beyond the initial trial results, which have recently been presented at the Union and CROI meetings. So I'll now hand over to Gustavo to introduce himself and the next two speakers. Thanks.
Yes, thank you very much, Angela. So, and welcome again to the participants and our speakers. So my name is Gustavo Velasquez. I'm an assistant professor at the University of California, San Francisco, in the Division of HIV, ID, and Global Medicine. It's my great pleasure to introduce my colleagues in the third and fourth speakers in our session. So first, Dr. Patrick Phillips is an assistant professor here at the University of California, San Francisco, in the Division of Pulmonary Critical Care and Department of Epi and Biostats. And his main research focus is to design, implement, and optimize clinical trials for new treatments for tuberculosis. And Dr. Marjorie Imperial is a postdoctoral research scholar in the Department of Bioengineering and Therapeutic Sciences under the mentorship of Dr. Radha Savage. And she is one of our TB ramp scholars, and we have several presenting today. Dr. Imperial's research focuses on integrating data from multiple sources and applying pharmacometric approaches to quantitatively characterize the interplay between disease dynamics, optimal regimens, and treatment response for patients with TB. So with that short introduction, we'll go ahead and begin the first presentation by Dr. Annabelle South. Thank you.
Treatment for drug-resistant TB is prolonged, challenging to deliver, and has high default rates. But recent years have seen progress in the development of new treatment regimens, giving clinicians and patients more options. This raises the question of how do we choose between them when they may have very similar efficacy in terms of culture results. For this, we need to understand what matters to patients and then look at how the different treatment regimens affect those things. To explore this, we carried out focus group discussions for people undergoing or who had recently completed treatment for drug-resistant TB. 3 focus groups each took place in Georgia, Mongolia, and South Africa, with a total of 55 participants. Almost all participants had been on oral regimens, some as part of trials. About half of the South African participants were living with HIV. We used story stems where the facilitators set the scene and asked participants to say what happens next in the story to explore the different parts of the treatment journey, from the initial diagnosis of the story's main character with drug-resistant TB, through to learning they were no longer culture positive, right through to the end of treatment. The focus groups were recorded, transcribed and translated, and then analysed using a thematic analysis approach with both inductive and deductive coding. Codes were then grouped into themes, and super themes were created which brought together related themes. In this presentation, I will give an overview of the themes we found in our analysis and focus in on those that are most relevant for decision-making around treatment regimens. Our first super theme is treatment experience and the role of good relationships with practitioners. Our second is mental distress and the opportunities for positive well-being. And our third is understanding fear and worry along the treatment journey. Concerns about treatment primarily related to the length of treatment, pill burden, and not understanding what each pill is doing, and also worry about adapting to changes in the regimen. I was scared I might die because of these medications. The first few days were difficult and I'd never taken such a number of pills in my life. Participants talked about many side effects, but the ones that were most prominent in the data were vomiting and nausea and fatigue and weakness. Side effects or symptoms that were visible signs of their illness seemed to be particularly troubling to people. For example, changes in skin colour or weight loss, perhaps linked to societal discrimination. Factors that motivated participants to continue their treatment included preventing TB from coming back, desire to return to their old life, desire to protect others, and commitment to the clinic to complete the course of treatment. Encouragement from family and support from the clinic facilitated people to keep going with their medication. There were 2 main conflicting reasons for stopping treatment or having poor adherence. Firstly, if the patient is feeling better, they may decide that they don't need to continue treatment or be distracted from treatment by other activities. Adhering to treatment may be particularly difficult if you need to return to work. Secondly, if the patient experiences bad side effects, they may find it hard to adhere to treatment. Features of an ideal treatment include having a fast, visible impact so people feel encouraged, not to cause vomiting, shorter duration or fewer side effects. Some participants seemed willing to take drugs for longer if the side effects could be reduced, while others wanted shorter treatment. I think it's better to get medication that shows change or difference very fast, so that would be getting something that would make one gain weight, because that will mean the medication is making a difference. I wonder if it is possible to make drugs with no side effects. If there is such a treatment, it is not important to reduce the time, but the side effects. The drugs that would make you at least not feel dizzy, nauseous. It would be much better if they could come up with a form of treatment that takes less time to complete. In terms of relationships with healthcare professionals, communication and trust was important. The information given by clinical staff could be instrumental in changing perceptions of TB disease and treatment. Good relationships with clinical staff could help combat fear and uncertainty regarding treatment. However, some participants highlighted a lack of communication as a problem, meaning they were unsure of the treatment process, including what they can expect, what side effects they might have to deal with, and why they must take the different medications. This adds to psychological and emotional instability patients were experiencing. The level of support from healthcare providers varied between the countries, with South African participants talking about how the staff and system supported them in their treatment journey, while in Mongolia, participants felt they could have benefited from more psychological support. In South Africa, participants talked about using their experiences to talk to others about TB and being living testimonies that drug-resistant TB can be successfully treated. Treatment experience and the level of mental distress diagnosis caused was influenced by societal and individual perceptions of TB and TB treatment. A diagnosis of DRTB could lead to patients experiencing stigma and discrimination. This differed between the countries we looked at, with seemingly less stigma and fear in Georgia than in Mongolia or South Africa. This stigma and discrimination could lead to loss of support networks as friends and family distance themselves, and also economic implications, with some people losing or changing their jobs. In South Africa particularly, this meant that some people struggled to afford food. As treatment starts to work and the patient becomes no longer infectious and finally cured, these relationships improve. The negative impact of TB and TB treatment on mental well-being was a prominent concern in the data. This includes feelings of depression and suicidal ideation, and emotional distress, loss of hope, confidence and self-esteem, broken spirit, unhappiness, and feeling unloved. People talked about changing their behaviour due to their experience of the disease, often being more cautious and reducing activities that might expose them to reinfection or other activities perceived as risky. TB disease and diagnosis meant that people had to give up work or school and may be unable to do household chores, which had knock-on effects to their finances and relationships. Participants considered resolution of visible symptoms as a return to normal. Persistence of visible symptoms hindered their ability to return to normal, whether due to their personal physical health or other people's reaction to them. Particular symptoms included weight gain, appetite changes, skin changes, and coughing. Feeling better allowed them to resume household chores. Learning they were no longer sputum positive was an important point in people's treatment, as it enabled them to resume work and school and social activities. Positive treatment outcomes led to the return of positive emotions and regaining of self-esteem and confidence. Participants expressed many fears about TB. Fear of spreading the disease was common across all the countries. There was also concern that TB may return. In South Africa, participants raised fears about how far the disease had gone for them to require such a long treatment and how they had acquired the disease. There were also concerns that their life may be ending. The fact that I was infected was very stressful for me. Fears about treatment included concerns about the length of treatment and whether they'll be able to endure it, fear of side effects, the health consequences of treatment and of stopping treatment. These fears were particularly prominent in the South African data, where very specific concerns were raised. In the other countries, fear of treatment was more related to uncertainty about the treatment and how they will cope. Will I be able to take the pills every day? Will I be able to finish all these months? If it happens that I have a problem, that I am failing to take them, what will happen? Participants were concerned about the longer term implications for their futures, whether they'd go back to being their old selves and their relationships with others. It may recur any time, so I get permanent fear of it. Fear and worry seem to largely disappear at the end of treatment. It is important to understand the perspectives of people living with DRTB to make sure the treatment regimens we develop meet their needs and priorities. From our qualitative research of people currently or recently treated for drug-resistant TB in Georgia, Mongolia, and South Africa, in addition to the outcomes trials already measure, we need to find some way of assessing how good new DRTB regimens are at speeding up patients' return to normal in terms of social, physical, and economic activities. We also need to look at how we can reduce fear and worry along the treatment journey. The next step for our research is looking at which patient-centered outcome measures best capture these concepts to inform future trial designs. Thanks to the study participants and PPI contributors and teams at UCL, South Africa, Georgia, and Mongolia that have contributed so much to this research.
Thank you very much, Annabelle. Some fascinating insights to the patient experience there. So we're now going to move to the recording of Bernd Thomas and looking at, give us some insights from the TB PRACTECAL trial. Thank you.
And good evening, wherever you are. My name is Bernd Thomas Nyangwa, and I'm the chief investigator of the TB PRACTECAL trial. In the next 10 or so minutes, I'm going to take you along an abbreviated journey of PRACTECAL this far. TB PRACTECAL is a randomized controlled two-stage open-label phase 2-3 trial evaluating the safety and efficacy of drug regimens containing bedaquiline and pritomanid for the treatment of patients with pulmonary rifampicin-resistant TB. In stage 1 of the trial, participants were randomized to 3 oral 24-week investigational regimens and the standard of care. Arm 1, the BPAM regimen, consisted of bedaquiline, pritomanid, linezolid, and moxifloxacin. Arm 2, the BPAS regimen, contained bedaquiline, pritomanid, linezolid, and clofazimine. And Arm 3 contained bedaquiline, pritomanid, and linezolid. Of note, the linezolid dosing in TB PRACTECAL was 600 milligrams once a day for the first 16 weeks, reduced to 300 milligrams for the remaining 8 weeks. The control was in line with WHO recommendations for the standard of care, which consisted of different drugs that lasted between 9 months to 18 months of treatment. Following stage 1 data analysis, all 3 investigational arms were deemed to have met the criteria for stage 2 eligibility. No major safety signals were detected. The Independent Scientific Advisory Committee, having reviewed blinded data, recommended that PRACTECAL Arm 3 should not continue to stage 2. For pragmatic reasons, the steering committee decided that Arm 2 as well should not continue to stage 2. Therefore, stage 2 of the trial consisted of PRACTECAL Arm 1, the BPAM regimen, in comparison to the standard of care. TB PRACTECAL was implemented in 3 countries: the Minsk site in Belarus, the Nukus and Tashkent sites in Uzbekistan, the Doris Goodwin, Don Mackenzie, Helen Joseph, and King Dinuzulu sites in South Africa. The PRACTECAL journey, however, started just under 10 years ago, when the standard of care, as you know, was lasting up to 24 months, with injectables up to 8 months, and with severe adverse events including deafness. Bedaquiline and delamanid were now visible in the pipeline. So in 2013, we published principles that guided the search for trial combinations. It was not until 2016 when we secured access to the drugs and finalized the trial protocol. In January 2017, we recruited the first participant into the TB PRACTECAL trial in Nukus, Uzbekistan. And the last participant was recruited in March 2021. In between, of course, the standard of care had changed several times and in different ways in the different participating sites. Political instability at some point threatened the closure of one of our sites. And of course, COVID was threatening to derail everything from the beginning of 2020. Following the Independent Data and Safety Monitoring Board recommendations, we terminated randomization into the trial, and a couple of months later, we locked the database. We then shared the preliminary results in October last year at the Union Conference, and earlier this year, we also shared all 4 arms results at the CROI Conference. This is a forest plot of the main efficacy results. The unfavorable outcome proportions are on the left. The first column is showing the numbers and proportions in the standard of care, and the second column is showing the investigational arm numbers and proportions. The risk difference to the standard of care is on the right, including the confidence intervals. In the main plot in the center, the dotted vertical line on the right delineates the 12% non-inferiority margin. The BPAM regimen demonstrated non-inferiority in both the modified intention to treat and the per protocol populations, as demonstrated by the upper bound of the confidence interval falling below the non-inferiority margin. In the modified intention to treat population, the confidence interval was below 0, demonstrated superiority of this regimen to the standard of care. The BPAS regimen demonstrated non-inferiority only in both the modified intention to treat and the per protocol population, as seen by the confidence intervals of each of those. While the BPAR regimen demonstrated non-inferiority in the modified intention to treat population, but not in the per protocol population. This is demonstrated in the per protocol population confidence intervals extending beyond the 12% non-inferiority margin. In the main safety analysis, the proportion of participants with at least one serious adverse event or a new grade 3 or above adverse event were 58.9% in the control, 19.4% in practical arm 1, 31.9% in practical arm 2, and 21.7% in practical arm 3. In order to support global health, programmatic and clinical decision-making on the use of this regimen, we also conducted several sub-studies. We conducted the economic evaluation sub-study, the patient-reported outcome sub-study, and the pharmacokinetics and pharmacodynamics sub-studies. All of these sub-studies are ongoing, but some of the preliminary analyses have already also were shared with the World Health Organization. In conclusion, the BPAM regimen is both non-inferior and superior to the standard of care. 24-week or oral regimens containing a backbone of bedaquiline, pretomanid, and tapered dose linezolid are both safe and efficacious in the treatment of rifampicin-resistant tuberculosis. Although TB PRACTECAL was not designed to compare the investigational regimens against each other, from an efficacy perspective, we've observed that the BPAM regimen is better than the BPAS regimen, which is better than the BPAR regimen, and all three are better than the standard of care. And from a safety perspective, the BPAM regimen is better than the BPAR regimen, which is better than the BPAS regimen, and all three are better than the standard of care. However, the journey is not yet complete. People suffering from DRTB need access to these much improved treatments without delay. I would like to sincerely thank all the participants that volunteered to be part of the TB PRACTECAL trial. I would like to also thank the partners and collaborators for all the organizations on this slide. And thank you for the organizers for inviting me to make this talk. Thank you.
Okay, well, thank you so very much, Dr. Nyangwa, for that presentation on really what I believe is already a landmark clinical trial that I have firsthand experience knowing that it's already changing practice and has since that announcement last year when enrollment was stopped. So now we're going to switch gears and have a presentation from my colleague, Dr. Patrick Phillips, a live presentation, and he is going to talk about another innovation that really focuses on one of the things that really matters to patients, which is duration of treatment. And so this is about duration randomization, 3 clinical trials. Thank you, Patrick.
Thank you, Gustavo. Thank you very much. I'm very grateful to the organizers for allowing me the opportunity to present here. And we've talked about these designs, looking at optimizing the duration of treatment for a number of years now. And it's great to talk now about 3 specific trials where this design is entering the field. And so I have the opportunity now to talk specifically about these 3 trials and how we're looking to optimize duration in clinical development of new regimens of tuberculosis. So there are three components of a TB treatment regimen, and I just talked very briefly about how we go about evaluating those three components in clinical trials. Now, the first question, of course, is which drugs, and this is explored in the clinical pathway in phases 1 and 2 and confirmed in phase 3 trial. The second part is what doses of these drugs we should give. This is generally explored in phases 1 and 2, and then confirmed in phase 2 and potentially phase 3 as well. But the third question, for what duration, is one that really hasn't been addressed and hasn't been explored very much in phases 1 and 2 of development. It's really just something that comes in phase 3. And so I'm going to talk about phase 2 trials using this duration randomized design, seeking to really get a better handle of how long we should be giving treatment even before we get to phase 3. So these are the three trials I'm going to talk about. Spend most of my time talking about DRAMATIC, which is the furthest ahead, which is due to start enrolling patients very soon. I'll talk about SPECTRA TB, which is a protocol in development thinking about treatment stratification in the context of duration. And then UNITE for TB phase 2C, which is a multi-arm platform trial. So thinking about multiple regimens and duration. So DRAMATIC is a phase 2 study. You can see the partners who are involved in this study presented there on the screen. This is a prospective duration randomized partially blinded phase 2 study. So the regimen being evaluated is a 5-drug regimen for drug-resistant tuberculosis. These are the 5 drugs listed here. All drugs are given once daily. And in terms of the design, let me compare it first against a typical phase 3 design evaluating a single duration. So this is study 31A 5349, which was published recently. And in this study, there was a control for 6 months and 2 4-month regimens. So in contrast, the DRAMATIC phase 2 trial doesn't have a control, just a single regimen, but looking at the single regimen given for one of 4 different durations. The shortest duration is 16 weeks, going up to 40 weeks, the longest duration. And participants are randomized to one of these different durations of the same regimen. The sample size is 220 participants, and this gives us 80% power to demonstrate a trend, namely a duration-response relationship from 60% in the shortest duration to 85% in the longest duration. So our objective is to describe that relationship between duration and response. This is an illustrative figure of what the trial results might look like at the end, just to explain how this sort of design can be used. So to see the red dots and the confidence regions represent the observed proportions, the potential, what we might see in the study. And because we randomize across these 4 durations, we can fit a duration response relationship. And that's what the gray line represents there. And so we can describe how efficacy changes to duration and then use this relationship to identify an optimal duration to take forward to a future phase 3. And as the trial has been come together and as the protocol's been developed, and indeed we've begun to have site initiation visits, there's a couple of operational issues and challenges that have come up as we've put this design into practice that I wanted to share. So first of all, in terms of blinding, we have in the trial, participants and clinicians are blinded to treatment duration, at least for the first 16 weeks. So there's no placebo, everybody's on the same treatment for 16 weeks. And so the actual allocated duration is blinded for that period. And what this means is this prevents knowledge of duration influencing management, at least over the first 16 weeks. And it also simplifies the procedures during recruitment. So there has been concerns about the complexities of different durations, but at least blinding means that the complexities come at the end of treatment, not at the beginning, when there's often a lot of things going on in the trial: informed consent, randomization, initiation of treatment. This is a comment from one of my colleagues. The design won't work if clinicians are uncomfortable stopping when the pharmacy says they should. This is a novel design looking at different durations of the same regimen. And so the trial team has worked hard on collaborative training to show the shortest durations can be successful, to help indue that confidence in the shortest durations that they can be effective in curing patients. And there's a clear patient management guide on treatment extensions. When the allocated treatment duration comes to an end, there's guidance about how to use the available data to make a decision about whether or not to extend treatment. The third issue I wanted to talk about is possible poor treatment response. This was used in study 31A5349. this is a standardized strategy for maximizing data collection when poor treatment response is suspected. And so what this means is that it allows for increased objective microbiological data for the primary outcome. So anytime there's a potential relapse or treatment failure, there's a standardized procedure for collecting additional samples to ensure that we get the best possible data collected in order to determine whether that was likely turned out to be a relapse or not. Fourthly, there have been questions about how retreatment works in this sort of treatment duration type trial. And so we have clear guidance on retreatment in the event of relapse or treatment failure. Frankly, this is the same for any trial of a novel intervention. And finally, just to raise the importance of the DSMB. So we will have regular DSMB review, as would be common in any phase 2 or phase 3 trial, but very clear guidelines about the possibility of dropping the shortest durations if they're unsafe. And so the DSMB will look very carefully at the number of relapses in the shortest durations, and they will have the mandate to stop the short durations if there's any concerns there about an unnecessarily high rate of relapse. Moving on to the second trial, Spectra TB, thinking about stratified medicine in the context of duration randomization. So there's work being done that actually presented the next talk from my colleague Marjorie Imperial, really showing that the individual risk of relapse is correlated with a limited set of baseline covariates. And so building on the results of study 31, A5349, which is the trial in the bottom corner, which showed that this rifapentine moxifloxacin regimen given for 4 months was non-inferior to control, Spectra is a phase 2C trial designed to optimize the duration of this regimen by risk strata, and the principle being the right duration for the right patient. And that Spectra will inform a future phase 3 trial evaluating a strategy of tailoring the duration to participant risk strata. And so this is the design. The protocol is in the planning phase at this stage. There's 2 stages of randomization. Participants were randomized initially to a control or to the rifapentine moxifloxacin intervention arm, a ratio of 1 to 5, 5 times as many in intervention. Participants will be stratified based on the risk algorithm. All participants allocated to the control regimen will get the same regimen, standard of care, 26 weeks of HRZE for all. Those allocated to the intervention regimen will undergo a second randomization. Those on the high risk will get the 24 weeks of the rifapentine moxifloxacin regimen. Those with low risk of relapse will be randomized among 5 different durations. And really the objective here is to evaluate a longer duration for those that need it, those that have a higher risk of relapse, and identify a shorter duration for those that don't. The sample size for Spectra is 780 participants. Based on data from study 31A5349, we expect about 3/4 will be in the low risk group and 1/4 in the high risk group. And it's notable that because we will see fewer relapses and failures in drug-sensitive TB than drug-resistant TB, this means that Spectra has a larger sample size compared to dramatic. So that's a difference between the drug DRTB and DSTB. The third trial I want to mention is in the context of the Unite for TB consortium. This is a public-private partnership. Here is my first slide of partners, and here is the second slide of partners. Here is a list of the individuals who are part of the design and analysis work package of this large consortium from a number of different institutions and organizations. And there's a slide about funding. So Unite for TB is a large, is a network of a number of trials looking at a number of different combinations. And I guess what I want to talk about briefly here is the phase 2C, which is a multi-arm duration randomized design. And this is broadly speaking how the trial will work. This is a little bit earlier in development. So patients will be randomized not only among multiple durations, but among multiple regimens as well. And so what will be key here, patients are followed for 52 weeks. Key here is regular DSMB review. And so the idea is there'll be interim analyses looking very carefully at the data by DSMB with the potential to stop the shortest durations of certain regimens where relapse rates are high. And you can see in my example here, regimen A, the shortest durations are stopped. Regimen C, the shortest duration stops. Regimen B and D continue. And at the second interim, we're only left with the longest durations for regimen A. And then in this example, with 2 interims, there's a final analysis with the duration response models fitted, and then identification, selection of the optimal durations for a future phase 3. And so that's really what this design would look like in the context of a multi-arm platform design. So just in conclusion, the first thing to say is the evidence to support choice of duration of a TB regimen can be generated in phase 2 trials. And I think what my intention really is to show that this duration randomization design is feasible and is a practical design for phase 2 trials, and really watch this space for results. Hopefully in the coming years, we'll be able to see how these designs work in practice. Thank you very much.
Great. Thank you so much, Patrick. That is really it's really exciting just to see that there's 3 clinical trials in, either in development or already, being planned or starting that are focusing on this very important issue of duration of treatment. And the way we structured this session is also for the next topic. So Dr. Marjorie Imperial will talk about something else that is, important to trialists, but also very important to patients, which is getting the right regimen, at the right for you, right, and specifically, not getting more or less. So with that, I'd love to turn it over to Dr. Imperial's talk about stratified medicine.
Hello, everyone. My name is Marjorie Imperial, and I'm a postdoc here at UCSF, and I'll be presenting on the lessons and knowledge gain in stratified medicine principles from the analysis that we performed with the TBTC Study 31 A5349 trial. Now, before I go into the lessons, I first just want to highlight the knowledge we had prior to the analysis of Study 31 A5349. And so we know that the majority of patients with drug-susceptible TB can be treated with standard dose regimens at durations that are shorter than 6 months. We performed a pooled analysis named the TB Reflect analysis of 4 phase 3 clinical trials that tested 4-month standard dose rifamycin-containing regimens. And in our analysis, we identified a low-risk population that reaches target cure rates whether they are treated with 4-month standard dose regimens or 6-month standard dose regimens. In addition, we also identified the high-risk population that do not reach target cure rates whether they are treated with the 4-month or 6-month standard dose regimens. This high-risk population drives the higher rates of unfavorable outcome and likely requires more potent or longer treatment durations than the 6-month standard of care. And so that brings us to the Study 31 A5349 trial. It's a treatment shortening trial for drug-susceptible TB that tested 2 4-month high-dose rifapentine-containing regimens with or without moxifloxacin substitution. HPZM is the arm that included the moxifloxacin, and then HPZE is the one without the substitution. These 2 regimens are the most potent 4-month regimens tested thus far for drug-susceptible TB. And of course, the HPZM regimen showed non-inferior outcomes to the 6-month standard of care. And this was a huge accomplishment for the TB field. But the question remains about how the knowledge we gained about stratified medicine principles from the analysis of standard dose regimens in our TB Reflect analysis translate to high-dose rifapentine regimens that were tested in Study 31. So jumping right into the lessons that we have gained from our PK/PD analysis of Study 31 A5349, the first is that the PK/PD modeling prior to Study 31, primarily based on phase 2B trials, predicted that solely increasing the dose of rifapentine is not going to be sufficient to shorten treatment duration. So here we're showing just a snippet of the results from our PK/PD analysis of phase 2B trials that preceded Study 31. In the phase 2B studies, the outcome that was modeled was time to culture conversion, and it was found that even with high rifapentine exposures, participants with large cavities at baseline had delayed culture conversion compared to those participants with small or no cavities at baseline. And there were at least 5% of the population that had large cavities that did not culture convert after 4 months of treatment. Now, if we look at the Kaplan-Meier plots for time to culture conversion from the Study 31 A5349 trial, we can see that those participants who were treated with HPZE and had large cavities, and so this red curve here, had delayed culture conversion, particularly after 2 months of treatment, compared to those participants who had small cavities or were treated with HPZM. Then if we look at the proportions of participants without TB-related unfavorable outcomes, including treatment failure and relapse, we see that participants in the HPZE arm, here in yellow, who we have defined as hard to treat, having higher bacterial burden and more extensive lung disease had higher rates of unfavorable outcome compared to those participants who were treated with HPZM or HRZE, the 6-month standard of care. Our second lesson from our analysis is that rifapentine exposure was the strongest predictor for unfavorable outcomes. And so study 31 A5349 represents the very first time where we have a phase 3 clinical trial that collected study-wide PK data for all first-line TB drugs. And so it's the first time that we can actually establish exposure-response relationships for the long-term outcome of relapse or treatment failures. And so taking a look at the Kaplan-Meier curves of the observed data stratified by regimen. So in blue, we have the HPZM regimen. In yellow, we have HPZE, and then also stratified by rifapentine exposure above the median exposure or below the median exposure. We see that participants who had rifapentine exposures above the median, so these solid lines here, whether they were taking the HPZM or HPZE arm, or HPZE regimen, they had high cure rates. However, for those with low exposures, they had much worse outcomes. And the inclusion of moxifloxacin, so this blue curve compared to this yellow curve here, substantially improved the cure rates for those with low exposures. And so for both regimens, we've now established target rifapentine exposures to maximize the cure rates above the 95% threshold. And focusing on just the HPZM regimen that has shown non-inferiority to the 6-month standard of care, we've established a target to be 570 microgram hours per liter. And using our model, we can predict how the proportion of patients in the study 31 A5349 trial that would have exposures above this target for a variety of rifapentine doses. And so for the 1200 milligram dose, about 50% of the population would reach this target that we've established for the HPZM regimen. Increasing the dose to 1500 or 1800 further increases the proportion of patients reaching the target and has the potential to possibly allow for even shorter 2 to 3 month regimens of HPZM. Our third lesson from our analysis is that the risk factors and stratification algorithms are consistent and validated with the new data from study 31 A5349. On the left here, we have the risk factors that were identified in our TB reflect analysis using the standard dose rifamycin containing regimens. And on the right, we have those risk factors that were identified in the study 31 A5349 analysis with the high dose rifapentine containing regimens. In the study 31 A5349 analysis, we had the opportunity to test newer and more quantitative markers of bacterial burden, like gene expert, cycle threshold, and additional chest X-ray readouts that were not available for all participants in the TB reflect analysis. And they were indeed they indeed outperformed the categorical smear grading for bacterial burden and cavitary disease yes/no readings from chest X-ray readouts. The fourth lesson is related to lesson number 3, and that stratified medicine principles remain relevant with high-dose rifapentine regimens. Using a very simple algorithm that only accounts for the top 2 baseline risk factors that are associated with bacterial burden, measured by gene expert cycle threshold, and then also the extent of lung disease and chest X-ray readouts, we can stratify patients into low, moderate, or medium, and high-risk groups. And if we take a look at the observed data Kaplan-Meier curves from study 31 stratified by these groups, we indeed see that there is a gradient in cure rates when we compare these risk groups, whether we are looking at the HPZE or the more potent HPZM regimen. Again, the high-risk group did not reach the target cure rates, whether they were taking the HPZE or HPZM regimen. And so really this group still needs more potent treatments in order to maximize cure rates. And the phase 2C Spectra TB trial that Patrick has introduced is being designed to test stratified medicine principles and to determine the optimal treatment duration for each of these risk groups. The final lesson is about how well our current risk algorithms can discriminate the risk between patients. At the moment, we are describing our algorithms as being modest with an AUC ROC of 0.72, but only including the baseline clinical risk factors. However, if we include the individual drug exposures, then the AUC ROC improves to 0.77. It's important to point out that although they are modest and they are not reaching a threshold of 0.8, for example, for the ROC AUC, they are adequate, or our risk algorithms are adequate for stratified medicine, because the goal of stratified medicine at the moment is not to assign the optimal treatment duration for each individual patient, but instead to assign risk groups and then determine the optimal treatment duration for that risk group. The markers in the algorithms, our current algorithms, are practical and routinely collected in at least clinical trials, but there is clearly still room to improve and deliver some more precise algorithms. And so those are the lessons that we have gained so far with our analysis of the Study 31 A5349 trial. And with that, I would like to thank many who have been involved in the analysis, particularly the Spectra TB team that is working on designing the trial. A special thanks to Vincent Cheng, who has been really the one that has been performing a lot of the Study 31 A5349 analysis. Rada Savik, who is my mentor, and the entire Savik Lab for their support and guidance. The Center for TB and the TB RAMP program that I am part of, the ACTG and TBC trials consortiums that provided the data and sponsored the Study 31 A5349 clinical trial, and then also our funding.
Okay, well, thank you so much. So now I'm very excited to open up. We have 10 minutes for moderated discussion and Q&A. We've already received some questions in the Q&A box, and feel free to put in more to those watching. But we are going to have all our speakers here, and this is such a treat. So I think I'll let Angela, I'll let you start with the first question.
Great, yes. Thanks everyone. That was really, really brilliant. So first question I have is for Annabelle. And from your presentation, my impression was that from the results that for patients, the most important, what was more important was reducing side effects or reducing the fear and worry about potential future side effects for taking drugs for a long time, many drugs for a long time. Rather than just about treatment shortening per se. Is that a fair conclusion? And have you got any further comments on that? Thanks.
Side effects was a big issue for participants, and pill burden was also an issue. Duration was a challenge, but I think patients seem to accept that there was some kind of trade-off between side effects and duration of treatment, and perhaps different people would choose different options if they were given those choices. The next stage of our research is really to go back to some patients to try and prioritise the treatment-related themes that came out of the first round of qualitative focus groups, to try and really kind of get them to prioritise it in some order to help us with the next stage of work around identifying patient-centred outcomes.
Great, thank you. Gustavo, did you want to take the next question?
Sure. Yes, thanks so much. So Bern, I'm going to ask you a question here from the Q&A and add a little spin of my own at the end. So Tom Yates asks, as I understand it, the PRACTECAL result is largely driven by differences in treatment completion, and it's a question rather than deaths or relapse. A priori, I would expect better treatment completion with a shorter regimen. However, as a patient, I think I would be more interested in relapse or death. So how will the early termination of recruitment impact our ability or power to understand differences in relapse and mortality? And I think just to go even a little further, I'd be curious to know how you think the results for arms 2 and 3, the ones that were stopped, might impact their uptake in guidelines. So thanks, Bern.
All right, thanks, Gustavo, for the questions. I think indeed, when we looked at the differences in because the primary endpoint for PRACTECAL was a was a combined one, a composite outcome, and it included discontinuation. I think it's, and when you look at the differences, you would see indeed that the discontinuation outcome was the one that drove most of the analysis differences. However, I think it's important to recognize that the definition of discontinuation within PRACTECAL was very specific to the trial. Some of those in programmatic settings, you would define them as failure. So patients that were not tolerating treatment, and we had a really low threshold for treatment toleration to discontinue, simply because at the time when we started PRACTECAL, of course, there were concerns about bedaquiline, there were concerns about pretomanid and a couple of years back. So we had a really low threshold for discontinuation that we used to do that. So this is really the main part. But I think as you could see then in our per protocol analysis, that indeed then the results were mostly non-inferior, which when we excluded the discontinuation outcome, which then still just confirmed of what the reality that the regimens were doing at least as well as a standard of care if patients were able to complete treatment on the standard of care. On the other part of that question you're asking, indeed, the trial has three investigational arms. The bedaquiline, pretomanid, linezolid, and moxifloxacin arm, the PRACTECAL arm 1, was the one that we took to stage 2, and therefore the full randomized controlled trial setup was for that particular arm. The other two arms, we actually have analyzed them further as additional analysis. This was not the primary analysis that we predefined, but it was because we stopped early, as you mentioned, due to efficacy. But then also the transition from stage 1 and stage 2 was quite long. So the result was that the numbers were quite significant. So we felt that it was useful to share those results as well. So indeed, I think they indicate something in terms of efficacy and safety, but those numbers were not part of the primary analysis that we had anticipated. So there might be other additional steps to be taken to look at the confidence around that.
Yeah, thank you so much. And back to Tom's question, in the first part, I think that it's really an affirmation that, of course, relapse and death are top of mind for anybody who's entering treatment. But the fact that the standard of care has such poor kind of treatment completion and changes, it already is an indictment of kind of what the standard is to begin with, right? So thank you so much for that. Angela, do you want to take the next question?
Sure. I'll take the next one that came through on the Q&A. So we, assuming that this is related to the trials that were the data, the presentations that had trial data. So first of all, to Marjorie, then there was just to confirm that were there any differences in the hepatotoxicity rates seen in the intervention versus standard regimen in study 31.
In study 31, there were no differences in, no significant differences between the ifepentie and moxi arm, between the control arm, if we're thinking about any and all grade 3 or higher adverse events. We also, I don't believe there were any significant differences seen also for hepatotox specifically.
Okay. Oh, great. Okay.
Yeah.
And then the same question to you, Bern, for TB PRACTECAL. I know you showed the grade 3 and higher adverse events by each intervention. I'm not sure, did we see the hepatotoxicity? Was there any observed difference in TB PRACTECAL?
So no, I did not show the detail, but in fact the standard of care still had higher numbers with regards to hepatic, kind of grouped hepatic events. They had a higher numbers, and the Also, the clofazimine arm had slightly higher numbers, but again, keeping in mind around the full sample size that we ended up having, and the number of events were not very high that we could directly compare those. But indeed, there weren't any significant concerns around hepatotoxicity in the practical regimens.
Okay, thanks, Bern. I'm going to hand back to Gustavo. I think there's a question for Patrick.
Yeah, thanks so much. And unfortunately, we're of course running out of time, and I wish I had 20 more minutes to ask you questions. But Patrick, I'm curious about this is a really critical issue for these duration randomization designs. You mentioned that unblinding, so to speak, at the beginning of treatment is already kind of would be potentially problematic because people have to commit to receiving that short course, and they would know that ahead of time, versus knowing it kind of, at the end when you reveal, okay, you have a shorter course. So I'm just curious, if patients or clinicians or both are uncomfortable with stopping, and patients, for whatever reason might exit the trial even at the end, when it's revealed, what do we do to kind of preserve the quality of the data that would come out of the trials? Do we enroll longer? What do you think?
So the dramatic trial, so I guess this is talking about different durations in terms of risk stratification. So none of the trials I talked about had started yet. So we don't have any experience in terms of exactly what it looked like in practice. As I said, dramatic is further ahead, and there's been a recognition, a buy-in from all those involved, the investigators involved, of the importance of shortening treatment and of the appropriateness of the short regimen. And ethics committees have approved the trial, and the appropriate regulatory agencies. There are processes in place at the end of the allocated treatment duration to try to assist the treating clinician in considering extension of treatment. So I think that's been a concern, but I think it's not any different in many ways to any trial of a new intervention, where there's obviously uncertainty about how the intervention will work, but there's a partnership in moving forward in ensuring that the trial goes ahead. Does that answer the question, Gustavo?
Yeah, no, I think that it's going to be kind of lived experience. It seems like dramatic is really the kind of the spearhead here, and I think learning from that experience as these trials are implemented, and kind of further refining this process, if there's any lessons to be learned. Yeah.
And can I just respond to Liz's question as well, Liz Corbett's question, if that's okay, just briefly, if I can take the prerogative.
Sure.
So thank you, Liz, for the question. So Liz asks, what kind of support clinicians in resource-poor settings are going to need to manage risk stratification for personalized regimens reliably. I mean, I'm not really sure, Liz, what you're asking. In Marjorie's presentation, she showed that the risk factors are going to be readily available markers that are available in practice, in TB clinics: gene expert circle thresholds, HIV status, sex, BMI, extent of lung disease on chest X-ray. Maybe X-rays are not available, but these are data readily available at time of diagnosis. So the complexity in applying those markers hopefully is not too much. And the point I made earlier, at least in Spectra, that the difference by risk strata is in the duration, and so it doesn't add complexity at the time of diagnosis, but more at the end of treatment. So maybe this is more of a discussion about what you mean by what kind of support clinicians in resource-poor settings are going to need. But the idea is these are readily available baseline markers.
Great. Well, thank you so much. I am getting, we have to stick to our schedule. And so thank you so much for everybody's answers. I think I would encourage the panelists to answer via chat if there's remaining kind of questions that come up for your sessions. So with that, really thank you all so very much for your presentations. And we're going to take, I think we're going to either take a very short break or just move straight to session 2. Thank you all again.
Hello, everyone. I know it's a very short break. We have a very full schedule today, so we want to keep ourselves on schedule so that we can get through everything. So welcome to session 2. And I think in the theme of both our keynote speakers and the session we just listened to, really listening to TB patients and personalizing treatment options, we're moving into this session where I think we'll hear very similar themes from our 3 speakers. So we've titled this session, Bringing TB Science to TB Patients, Policy, Program, and Implementation Innovations. To introduce myself, my name's Dr. Christopher Berger. I'm an assistant professor and physician in the Division of Pulmonary and Critical Care Medicine here at UCSF, clinically based at San Francisco General Hospital. So I have the distinct honor of moderating this session. And I just would like to remind everyone that we will first hear from our 3 speakers, and then we'll have a moderated Q&A similar to our last session at the end. So please put any and all questions into the Q&A, and then we will get to them at the end of the 3 talks. To introduce our 3 speakers now, we'll first hear from Dr. Jennifer Flood. Dr. Flood is the chief of the Tuberculosis Control Branch at the California Department of Public Health. She's an infectious disease physician and a clinical professor of medicine here at UCSF. In her capacity as TB state controller, Dr. Flood has led the development of now 2 TB elimination plans for the state of California, and will be presenting on the most current plan and the path and progress towards TB elimination in California today. We will then transition to hear from Dr. Aditya Kadamachi. Dr. Kadamachi is a professor of medicine and epidemiology, and the new co-director of the Partnerships for Research and Implementation Science for Equity Center, or the PRIZE Center, here at the University of California, San Francisco. His research focuses on the development and evaluation of TB diagnostics and improving delivery and uptake of TB services in high-burden countries. We will then hear from our final speaker, Dr. Sachin Silva. Dr. Silva is a research scholar at the Institute for Global Health Diplomacy and Delivery, and he is working on understanding the economic welfare consequences of tuberculosis. And so to that end, he'll be presenting to us on recent global estimates of full income losses due to tuberculosis mortality. So with that, I'll turn over to listen to Dr. Flood's presentation.
Hello, this is Jennifer Flood, California TB Control Branch Chief. I'm super excited to speak to you today on our TB elimination strategy in California. And in California, tuberculosis really continues to disrupt lives, often in tragic ways. Half of those ill with TB are hospitalized, and 1 in 10 die during TB treatment, and even more in the 5 years that follow illness. Allowing TB to persist comes really at great cost to California. Each year, we spend close to $200 million for this single disease that is preventable. In addition to mortality and cost, there are also very striking disparities in disease burden. For example, non-US born Asians living in California have 50 times the TB rate of US born whites. And the majority of those who develop TB live in the least advantaged areas and face fewer opportunities for care. So a very vulnerable population develops TB. During the pandemic, we all experienced and witnessed that a lethargic disease decline really is a costly one. And this insight especially resonates for those of us working on TB. When we look at the California example modeled here, we see it's very expensive to accept the status quo. But if we change the pace of TB decline, we can save enormous numbers of lives and dollars. So, what intervention do we need to achieve this type of change? Our driving force for TB disease burden in California is latent TB infection. That's what's driving our disease trajectory. 85% of active TB disease begins as latent TB infection that's untreated but could have been prevented. Over 2 million Californians and 1 in 4 non-US born Californians have latent TB. Most infection is undetected and most is untreated. Yet the treatment for preventing TB disease in an individual is 50-fold less costly than TB disease treatment. So how do we create change? Our 5-year TB elimination plan focuses on mainstreaming latent TB testing and treatment. The plan outlines 5 recommendations and 40 action steps to reach people at risk and link them to TB prevention services. It helps providers become proficient at delivering LTBI testing and treatment. And it really calls for surveillance systems to be put in place that can measure and feedback outcomes, as well as securing new resources for TB elimination work. And relevant to our discussions today in this summit, the plan recognizes the real pivotal role of research, that it's critical for telling us which interventions can make the most difference. So some of the exciting efforts supported by our plan are shown in this slide. To engage persons at risk and the providers who serve them, a large TB awareness test and treat campaign led by CDC was just launched in Los Angeles and Orange counties. Hepatitis B Free Los Angeles has also been an organization that has led innovative work performing risk assessments on persons who are waiting after receiving their COVID vaccination, and then linking persons who are found to be at TB risk to testing. TB Free California, which is a state-based team, is collaborating with over 25 primary care clinics to assist with LTBI testing and treatment scale up. And we've been doing this for now a number of years. To support healthcare providers, a community of practice started in San Diego is also now being replicated in other parts of California. So LTBI testing and treatment, to be mainstream, must be supported by some new tools. And we have a new playbook that steps providers through best practices in the LTBI care cascade. And we also have a linkage to care made simple guidebook that helps connect patients who test positive to treatment, telling them where they can find care. Here in San Francisco, an EPIC smart set was developed for busy primary care practitioners to automate actions through the LTBI care cascade. And then finally, at a state level, we're working on low-cost solutions for drug and test access so that patients, regardless of their ability to pay, can get the care they need. Now, measuring latent TB testing and treatment in California over time is super critical for evaluating whether we're successful. A positive interferon gamma release assay result is now a reportable condition in California. And so those reportable results can lead to individual provider action, health department action, and also allow us to look at populations that have high prevalence of infection. We're also analyzing Medicaid data to reveal the TB prevention outcomes for one of the largest groups of Californians at risk. An investment in TB elimination has been challenging, really, across the globe, but we're now building an economic case that is very strong for TB prevention and disseminating to those who need to advocate for their work. We have an active coalition who's doing a stellar job and has created a funding proposal to bring the resources that are required to our TB elimination work. Finally, a statewide research network focused on LTBI has been established, and we're super excited about, in parallel, 5-year LTBI prevention studies that are in progress in 2 large primary care settings in Northern California, Kaiser, Northern California, and Northeast Medical Services here in San Francisco. And we are very much anticipating that we'll be creating some models that will be really efficient and effective in primary care settings that can really create a high degree of testing and treatment completion. So as these actions proposed in our TB elimination plan unfold, what are we hoping to achieve concretely? The 5-year targets we set, illustrated here, are based on some modeling we performed and mark the case count and disease disparity reduction that we think is achievable in California. The LTBI testing and treatment scale up will get us close to pre-elimination, and then we'll be ready for transformations that we are really excited about that will come through science, whether it's a new test, new treatment, vaccination, as well as super strong global implementation. Now, to close, I wanted to make the assertion that we can significantly lessen the TB suffering in California by these upstream prevention efforts, even with the somewhat primitive tools we have today. But we really do need those scientific advances, and we need a really awesome global investment. So all of this together is required for us to kind of hit the finish line and make our world TB free. I wanted to thank all of those who have brought this California elimination plan to fruition, and all of you working here today on ending TB. You can find our TB elimination plan if you're interested in more details on our website, and also by contacting Araxi Poloni at our TB branch if you'd like a hard copy. Thanks so much.
Thank you so much, Dr. Flood. It's really exciting to see what's happening here in the state of California and your very ambitious and impressive plans. So for everyone, please again put your chats in the Q&A section or your questions, and we will be able to ask those of Dr. Flood at the end. We will now move to listen to Dr. Aditya Katamachi. He will be talking about his multi-component strategy with decentralized molecular testing for tuberculosis, the EXPEL TB trial results. Go ahead and take it away, Dr. Katamachi.
Great. Thanks, and good morning to everyone in the Bay Area and the US, and good evening to those who are hanging on in London. I'm excited to share the results of this trial with you all today on World TB Day. So this trial is really focused on kind of this critical challenge that remains around sort of TB case detection. On the slide, you see one example of a cascade of care from India, which has been repeated now in sort of many countries and shows similar results. What I'd like to highlight are that the largest gaps are really in kind of the area of case detection, right? And these are really kind of compelling because these are patients who are actually reaching health centers, but either failing to be diagnosed with TB or failing to be registered for treatment if they are diagnosed. Our colleagues in London just published a nice meta-analysis in the Gray Journal showing that on average it's only about 38% of patients with TB symptoms are actually offered even testing for TB. So I think this really represents a huge failure on the part of the health system in terms of actually sort of achieving sort of detection and linkage to care for patients who are making the effort to sort of reach our health centers. We've designed sort of a series of studies over the past 5 years or so focused on sort of understanding and improving sort of gaps in this cascade of care. The first aim has been to really quantify these gaps at health centers that are linked to sort of gene expert sort of testing sites. As all of you know, the expert MTB RIF assay is now the sort of first line sort of recommended test for TB and has been sort of widely scaled up in many sort of high burden countries. Second, to kind of identify modifiable barriers at the provider, patient, and health system level to delivering high quality TB diagnostic services. And last, to develop and evaluate a theory-driven intervention to improve the quality of TB diagnostic services. Because of time, I'm going to really focus just on the last aim, the actual intervention evaluation. And just want to highlight that this intervention that I'll describe was really developed through a lot of sort of formative research trying to sort of understand and address the barriers to care. So the Expel TB intervention strategy involves sort of three components. The first is sort of on-site expert testing at lower level health centers. So this is enabled by kind of newer sort of testing platforms like the GeneXpert Edge platform, which is battery operated and has a dust-resistant cover, both of which make it feasible to sort of implement at lower level health centers without sophisticated sort of laboratory infrastructure. And the goal here was really to reduce the workload of health center staff and also to increase the speed and accuracy of TB testing. The second component of the intervention is sort of what we call structured process redesign to facilitate same-day testing and treatment of TB. And what this involved was sort of going through a lean or quality improvement-like process to remove efficiencies in the kind of symptom screening and then referring patients to the lab to actually get testing and followed by delivering them results. So this was done in a standard and structured way at each of the intervention health centers to address the lack of urgency around TB testing that we identified in our formative research, and also kind of the failure of patients to return after their initial visit, largely due to the high costs of accessing sort of health centers that have been documented by many others. And last, the intervention involved regular feedback of quality metrics to health center staff, and this involved essentially providing a report card monthly of sort of each of the steps in the cascade of care. And this was to improve communication, coordination, and oversight between health center staff and also sort of district TB officers who are charged with overseeing TB services at the health centers. So in terms of the trial design, the objective was to evaluate the effectiveness, implementation, and cost effectiveness of the Expel TB strategy at community health centers. It was a cluster randomized type 2 effectiveness implementation trial at 20 community health centers in Uganda. And really the population was all adults being evaluated for pulmonary TB. We excluded patients with RIF resistance, primarily because, as many of you know, drug-resistant TB it requires sort of referral to sort of higher level or specialty centers of care for treatment initiation, and so that wasn't really the focus of this study. In terms of trial procedures, what I want to highlight was the highly kind of pragmatic sort of nature of this trial, which is kind of an innovation and difference from sort of many previous trials evaluating diagnostics or novel diagnostics. The picture is from a kind of a public randomization ceremony that we held where health center representatives actually participated in the randomization process, which helped to build trust and to enable sort of really kind of engagement of the health centers, regardless of whether they were randomized to the intervention or control arm. In terms of some of the other sort of pragmatic features, we did this trial under a waiver of informed consent since the intervention, really with just sort of expert testing, plus some, health system QI interventions were sort of low risk, and, GeneXpert was already approved both in country and by the WHO as the first-line diagnostic test. We had no trial-specific changes to the usual care that was provided in the routine care arm, right? So, for example, no chest X-rays, no culture, no additional sort of patient contact during the period of the trial. All of the outcomes were assessed using routine data sources, so we didn't introduce any additional sort of surveys or data collection instruments or additional sort of interactions with patients. And related to that, our research staff had very minimal contact with health centers. There was an initial training visit and then quarterly site visits just to resolve data queries and conduct some nested sub-studies. The primary outcome of the trial was the number of patients who were treated for microbiologically confirmed TB within 14 days. And the secondary outcomes reflect sort of process outcomes across the cascade of care. So the numbers tested, diagnosed with, and treated either for confirmed TB or for TB overall, both confirmed or empirically treated. And all of these outcomes were assessed within 1 day. So we were focused on sort of rapid diagnosis and treatment, as well as sort of within 14 days. The figure shows kind of the trial flowchart. There were over sort of 1,500 sort of health centers in Uganda that were linked to kind of GeneXpert testing hubs, and that was kind of the basic kind of eligibility criteria for health centers. In terms of the health centers that were excluded, most of them were because they were far away from Kampala, and that was just for sort of feasibility purposes. And so in the end, there were 84 eligible health centers and 20 were selected in consultation with the National TB Program and underwent randomization to 10 each to the intervention and routine care arms. During the trial, in each of these arms, there were more than 6,000 people who were evaluated for TB. Of these, about 1,000 in each group were excluded because they were less than 18 years old, and so you had about between around 5,500 adults, or about 10,000 total across the both arms who were eligible for the trial, and very few were excluded, right? So less than 2%, again, highlighting the pragmatic nature and really trying to be representative of all those who might be undergoing TB evaluation in routine care. So in the end, there were about 5,500 patients included at the health centers that were randomized to the intervention arm, and about 5,000 in health centers randomized to the control arm. In terms of patient-level characteristics, there were few differences between the intervention and routine care arms. So the proportion who were female, the median age, and the HIV status was very similar among patients enrolled or evaluated for TB in each of the arms. The primary outcome was analyzed in a cluster-level analysis using a negative binomial regression model. The models were adjusted for the randomization strata, and then some baseline data on the number of patients treated for confirmed TB within 14 days in the pre-trial period. And what you can see here is that the adjusted rate ratio was 1.56, which means that the number of patients treated in the diagnosed and treated within 14 days was about 56% higher in the intervention arm compared to the control arm. So a large, substantial increase in diagnosis and linkage to care. In terms of subgroup analyses, I think the key takeaway here is that regardless of sex and HIV status, there appear to be benefits in both men and women, as well as HIV positive and negative patients, and there were really no statistically significant differences between any of these subgroups. In terms of the secondary outcomes, what I want to highlight is that really what I hope the figure shows is improvement across the cascade of care. So in the numbers tested, the numbers diagnosed and treated on the same day, and also at 14 days. So really there was high implementation fidelity, meaning that we were achieving the same day testing and treatment that we had intended to achieve with this intervention, and then improved quality of care across the entire cascade. In terms of limitations, with any cluster trial, you can be concerned about imbalance in the underlying problems of TB or other factors by trial arm, particularly when the number of clusters is small. That said, we had a lot of baseline data on the health centers to inform the randomization to balance these factors as much as possible. A lot of people want to focus on the technology itself, so the new GeneXpert platform. But we thought it was important to really not just test the technology, but also health system co-interventions that can help increase its uptake. And so if you're interested in only the technology, this was a multifaceted intervention. And so the effect of decentralizing molecular testing alone, if that was your interest, is not addressed by this study. And last, generalizability. Obviously, this is a single country study. All of the health centers were in Uganda. That said, a lot of the same barriers to TB diagnosis and linkage to care exist, across many high burden settings. So in conclusion, what I want to highlight again is that the previous trials really just focused on novel diagnostics alone, and I think that's really a mistake. We really need to address the health system considerations that facilitate their uptake and use. And so our EXPEL strategy, which involved new technology with on-site expert testing, but also implementation supports, really substantially increased 14-day TB diagnosis and treatment, as well as same-day TB diagnosis and treatment, and improved quality across the entire cascade of care. We hope this spurs national TB programs to consider really investing in decentralized molecular testing, that the hub and spoke model that's been used is not really patient-centered and leads to sort of large losses along the cascade of care. And last, really, that, again, highlighting that it's not just the technology, but addressing barriers across for the entire cascade are important to achieve sort of high quality care. I just want to acknowledge really the hard work of particularly our team in Uganda and our collaboration with the National TB Program, who were instrumental in helping to implement the trial, as well as hopefully in disseminating the results. So with that, I'll end, and thank you and look forward to any questions.
Thank you, Aditya. That's really fascinating work. For time's sake, we'll move on quickly to Dr. Silva's talk next, looking at global economic costs of TB mortality.
Good morning, good afternoon, depending on where you are. Thank you to the organizers for the invitation to speak today. My name is Sachin Silva. I'm a research scholar and affiliate at the Center for Global Health, Diplomacy, Delivery and Economics here at UCSF. I am very excited to share with you our recent estimates of the global economic losses due to TB mortality and the economic impact of not meeting the SDG TB mortality targets, specifically the 2030 targets. When we undertook this work, there was a general belief that realizing the SDG 2030 mortality target of reducing TB deaths by 90% compared to TB deaths in 2015 was unlikely. With COVID-19, we felt that it was nearly impossible. So we asked 3 questions. First off, what is the life expectancy penalty of not meeting the target until, say, 2045, which we felt was a more realistic date? And then secondly, what is the corresponding economic penalty of not meeting the target until 2045? And then thirdly, what is the contribution of COVID-related disruptions to both the life expectancy penalty as well as the economic penalty? There were several considerations that we needed to take into account when estimating the economic penalty specifically. First off, we needed to account for the many channels through which TB mortality can exert losses. Secondly, we knew that the impact of TB mortality on national income growth is not fully known at a global level. And then thirdly, human capital-based approaches don't fully take into account the added value of living longer. Therefore, we decided to estimate the economic penalty in terms of full income, which represents the impact on national income growth and the added value of living longer. To contextualize our full income estimates, we also estimated losses in life expectancy, both at age 35 and at birth. The way we estimated full income, well, first off, we estimated full income under 3 scenarios for 120 countries from 2020 to 2050, allowing the target, the date for meeting the target to be placed in the middle of that time horizon that we considered. And we considered 3 scenarios, essentially. First off, if TB deaths declined at a steady 2%, the target is not met. The absolute worst case scenario, which we considered as the business as usual scenario, do nothing scenario. And then secondly, the best case scenario, which is if TB deaths declined at an average annual rate, allowing the SDG mortality target to be met in 2030 as intended, and then continued on that same trajectory until 2050. And then thirdly, if TB deaths declined at an average annual rate, allowing the SDG 2030 target to be met in 2045, which we consider to be a more realistic date. For each of these scenarios, we calculated full income losses, and we estimated the economic penalty as the additional full income losses that would be incurred due to not meeting the target until 2045, essentially the delta. And we call this the cost of inaction, which I will refer to through the rest of my presentation. The way we estimated full income was by first transforming the age-specific excess hazard of mortality due to TB to standardized mortality units, which is a 1 in 10,000 change in mortality risk. And then we calculated the population value of this risk change for each country and year by multiplying by the population in each age interval and rescaling the life expectancy loss using life expectancy at age 35 as a reference. And we then multiply this value by the value of a statistical life year for each country and year from 2020 to 2050, which we calculated as a proportion of the per capita income, which we modeled over 30 years. In countries where the value of the statistical life year was not empirically estimated, we calculated it based on benefits transfer, as is usually done. So here's what we found. First off, if the target is not met, the business as usual scenario, the absolute worst case scenario, we found that at a 2% annual mortality reduction between 2020 and 2050, there would be 31.8 million TB deaths, which amount to US dollars 17.5 trillion in full income losses in 2020, accrued at 2020, accrued between 2020 and 2050, but valued at 2020, assuming a discount rate of 3%. We also found that the highest economic losses would be in South Asia, which was $7.1 trillion. And we also found that the greatest effect on life expectancy would in fact be in sub-Saharan Africa, where on average a person would gain, if those deaths were to be averted, a person would gain 0.84 years in life expectancy in 2030, the midpoint of the time horizon that we considered. Conversely, if the target is to be met in 2030, as originally intended, this is the best case scenario, then we estimated that 23.8 million of the 31.8 million TB deaths would be averted, which in return averts 13.15 trillion of the 17.5 trillion in full income losses. We also found, that's a substantial share, by the way, we also found that TB deaths in people living with HIV contributes about 1.6 trillion to the 13.1 trillion in savings. And we also found that if the target is met in 2030, a person would gain about 0.26 years in life expectancy at birth on average, and 0.14 years at age 35, the peak productive years. Specifically, in a country such as Lesotho, we estimated that a person would gain nearly 2 years of life expectancy at birth in 2030 if those TB deaths were to be averted in the case where the target is met. Looking at the more realistic scenario, which is if the target is met in 2045, we estimated that 18.1 million of the 31.8 million TB deaths can be averted, which in return avoids about 10.2 trillion of the 17.5 trillion in full income losses. And therefore, and also meeting the target in 2045 reduces gains in life expectancy at birth by about 0.16 years, and at age 35 by about 0.09 years, compared to the business as usual scenario where the target is not met. Based on these three scenarios, we estimated that the economic penalty of not meeting the target until 2045, the cost of inaction, is $2.96 trillion, which results from averting 5.7 million TB deaths. We also found that the cost of inaction is highest in South Asia, where regardless of whether you include or exclude people living with HIV, specifically about 1.1 trillion, including people living with HIV, and about 1 trillion, excluding people living with HIV. We also found that the cost of inaction for people living with HIV is highest in sub-Saharan Africa, at 427 billion, which is nearly 6 times the next highest region, which is East Asia and Pacific. Specifically, to clarify, the cost of inaction for people living in HIV, in the previous case, it's the cost of inaction in total, which is highest in South Asia, The cost of inaction for people living in HIV specifically is highest in sub-Saharan Africa, as expected, at 427 billion, nearly 6 times compared to the next highest region. We also estimated, very importantly, that COVID-19 related disruptions to TB services can add at least US dollars 290.3 billion to the cost of inaction, which we previously estimated. So of the 2.96 trillion, COVID-related disruptions could contribute to 290.3 billion. In terms of life expectancy, we found that the cost of inaction really amounts to a reduction of about 0.1 years on average from life expectancy at birth, at the midpoint of the time horizon that we considered, 2030, and about 0.5 years on average from life expectancy at age 35, the peak productive, what we consider to be the peak productive years, which was also estimated at 2030. As key insights, to summarize, we found that aggregate economic losses are highest in South Asia and East Asia and Pacific regions. However, mean life expectancy losses per person, both at birth and at age 35, are highest in sub-Saharan Africa, nearly 6 to 7 times the losses in the next highest region. And also, we found that in sub-Saharan Africa, life expectancy losses also peak in the peak productive ages, which can deter economic growth. Overall, life expectancy losses in people living with HIV comprise as much as about 50% of the cost of inaction, specifically in sub-Saharan Africa. And we also found that countries that are more burdened by TB co-infections in patients with HIV accrue more life expectancy losses than countries that are more burdened by MDR TB. So we compared a set of countries which are considered TB HIV countries versus a set of countries which are considered MDR TB countries. Based on modeling that was available to us when the study was done, we estimated that the disruptions to TB services due to COVID will increase TB deaths until about 2025. That's where the accrual of those losses came and the contribution towards the cost of inaction. As limitations of our methods and the study, we would like to note that first off, full income estimates are inherently depressed where per capita incomes are lower because the share of income that an individual is willing to trade off for an additional year of life is, as expected, higher when per capita incomes are higher. But to account for that, we estimated the contribution towards life expectancy, which provides sort of a dual view on the impact. Full income also does not entirely capture losses due to post-TB morbidity and the cost of mortality in individuals who received treatment and then recovered. And then lastly, empirically established VSL values, which are not available for all countries, which are somewhat sparsely available if you consider globally. We estimated them based on benefits transfer, as is usually done. And it is also plausible that the mean individual valuation of mortality risk, which the VSL represents, is to some extent influenced by the presence of a global pandemic. And so both accounting for it in using benefits transfer and the possible variations given the presence of a pandemic contribute as a limitation. This work was recently published in Lancet Global Health, and I'm very grateful to my collaborators for their contributions, specifically Professor Nim Arinaminapati from the Faculty of Medicine and the School of Public Health at Imperial College London, Professor Rifat Attan from the Harvard T.H. Sands School of Public Health, Professor Eric Gooseby from the UCSF School of Medicine and the Center for Global Health Diplomacy, Delivery and Economics, as well as Professor Mike Reed, who's also from the UCSF School of Medicine and the Center for Global Health Diplomacy, Delivery and Economics. I thank you all for your attention. I hope the results are enlightening and insightful.
Thank you so much, Dr. Silva. I'm going to invite our 3 panelists to now join me. For a quick Q&A session, I think we'll have time for one question for each of our panelists. I'll start with you, Dr. Flood. The question that came through on our Q&A, it was expressing excitement around the fact that positive IGRAs are now reportable in the state of California, which I think is really wonderful. And so the question was just related to how the reporting structure will be organized and then the linkage to care, whether that be primary care or otherwise.
Thanks for that question. We have been really excited that California state law does now require laboratories to report positive interferon gamma release assay results. They do it through HL7 messaging. So this is electronic laboratory messaging. It comes into our statewide system, which we call CalReady, and goes to the local health departments as well. So these results are available at the state level, at the local health department level. The provider results continue to flow in the usual pattern. Laboratories immediately report back to providers those positive results. So in terms of linkage to care, most linkage to care and treatment, of course, happens at the primary care, ordering provider, treating provider level. And what we're trying to do to strengthen that is looking towards the future. We put into place this really cool platform, CalConnect, for COVID. Our TB team was really involved in that work. And we're now looking at some pathways like text messaging to patients that we have seen with COVID work well to connect patients and remind patients about their positive result. That is kind of future thinking. But right now, the results allow the local health departments and state health department look at where their positivity pockets are in populations. And it's kind of setting us up for a really cohesive system where we don't lose patients in attrition after the result is positive.
That's really exciting to see TB benefit from all of the innovation that came through COVID-19. So it's a very...
Can I just add one other subset? There is work that is successful right now where civil surgeons, those are physicians who must do TB testing on status adjusters, people applying for permanent residency here in California. All of those positive results are also coming through CalReady and through a provider portal. And the civil surgeons and health departments are now putting in the outcomes. Did the patient get referred to treatment? Did they get treatment? So we've started in some subsets of large swaths of populations, really starting to put the cascade of care together. And so we kind of see this as a kind of 2 and 5 year plan to be able to close the loop for people in California.
Thank you. Dr. Katamachi, the next question was for you. Your trial focused on uptake and reach and implementation of molecular testing for TB. And the question is just related to if you plan to do something similar with other TB diagnostics, either those that are currently available or if there are ones in the future that you're looking at, and how to conduct a similar trial to what you had done.
Yeah, great. Thanks for that question. I mean, I think there's certainly a need for cheaper, simpler, more accessible diagnostics for TB. We've been relying on sputum for too long, and identifying sort of non-sputum based diagnostics is a key priority for sort of the field. We're fortunate to have a large research program, which we call the Rapid Research and Diagnostics Development for TB Network, or the R2D2 TB Network, which is both. We have a large technology team led by Claudia Denkinger in Heidelberg, which reaches out to sort of product developers, especially trying to leverage the advances in COVID to help port them over to TB, and also sort of other product developers working in academia and industry. And then we have partnerships with high quality sort of clinical sites in 6 countries, 3 in Asia, 2 in Africa, and 1 in Central Europe, to conduct field studies of their accuracy and usability. And so right now we're evaluating, over 20 sort of novel tests, ranging from, face mask based testing to oral swabs to, blood and urine assays, and then some digital tools, innovative ways of using cough sound analysis and lung sound analysis for triage and diagnostic testing. So yes, certainly I'm very excited to advance promising assays from these accuracy and usability evaluations to implementation studies. And we are hoping to be able to do that in the next few years. And I think the EXPEL trial provides a nice model for how to do that.
Thank you. And moving on to Dr. Silva, it's always fascinating to see numbers put to the scale of the TB epidemic. And I am by no means a health economist. And so, I think we're often as public health practitioners, epidemiologists, used to seeing economic burdens discussed in cost of illness, productivity losses, DALYs, but you specifically focused on full income. And I'm just hoping you can give us a little clarity on how you distinguish that from the measures that we're often used to looking at.
Sure. And that's actually the most important question, because I presented large numbers. So it's very easy to compare those large numbers to previously established numbers. So full income, in summary, is how the increase in mortality risk for an individual translates into income losses. And it's not just that, it's that supplemented by the individual valuation of living longer. So, so being able to survive and work and earn, plus, the individual valuation, which takes into account various factors, which allows us to sort of get around the issue of, estimating each of the separate channels. The two combined are what I presented, and then sort of aggregated for 120 countries over 30 years. So that's why you see massive numbers. Now, that is subject to various assumptions around, and also parameter values that are available to us, such as the value of a statistical life, for example, which is not commonly established across the countries that we looked at. So we use numerous statistical methods to infer it. And that's why you see, the large numbers. They're not, it's not comparable to the cost of, excess spending on healthcare, or the loss in wages. It's just being able to combine that individual valuation of living longer, which provides this additional, sort of lens of losses in welfare. And that's what full income really represents.
Thank you. That's helpful. Well, thank you to all three of you. It's been a fascinating session. We're going to close the session. We'll have a quick 1-minute break, and then we'll start our third and final session. So thank you again to everyone.
All right, good morning, everyone. It's my pleasure to introduce the last session for today. Thank you for sticking with us. My name is Sarah Suleiman. I'm an assistant professor at the Division of Experimental Medicine at the San Francisco General Hospital at UCSF. So I'll be introducing our three speakers. The first one will be Dr. Paul Ogongo. Dr. Ogongo earned his PhD from the University of KwaZulu-Natal and Africa Health Research Institute, ARI, in Durban. Where he studied lung tissue resident memory T-cell responses to M. tuberculosis in humans. His research is focused on understanding the role of MTB antigen-specific T-cells in determining the outcome of MTB infections in humans. He's currently a postdoctoral fellow with Professor Joel Ernst at UCSF and the Helen Hay Whitney Foundation. Next, we will have Dr. Sarah Stanley, who's an associate professor at UC Berkeley with appointments in molecular and cell biology and the School of Public Health. Her work focuses on understanding effective immune responses to TB with the goal of contributing to the development of new vaccines, diagnostics, and therapeutics for the disease. Finally, we will have Dr. Matthew Kutis. Dr. Matthew Kutis is an assistant professor in the Department of Cell and Tissue Biology at UCSF. He's a TB ramp scholar, and his lab melds tissue engineering and cell biological approaches to construct and dissect complex morphogenic processes in human tissues in vitro. Today, he will tell us about his work together with the Ernst lab to build vascularized models for human TB granulomas. And with that, we will get started with Dr. Paul Ogongo.
Good morning, good afternoon, good evening, and welcome. My name is Paul Ogongo, and I'm a postdoc with Dr. Joel Ernst at the University of California, San Francisco. I feel honored to present here today as we mark yet another year of World TB. As we are aware that TB still has a lot of challenges, and in this slide here, I'm projecting only from the basic science point of view. There are other challenges in different aspects of TB research. We know that we have only one vaccine against TB, and that is the century-old BCG. However, we also appreciate that a vaccine against TB is highly desired, as highlighted by different TB working groups. Before the COVID pandemic, there was a lot of enthusiasm from TB field, and we had what could be called the year of TB vaccines, when we had very good results from M72 phase 2B trials, BCG revaccination studies, as well as use of BCG in non-human primates. However, looking at this data, this table from the World TB report, is that we have a lot of antigens that are on phase 2B and phase 3 and very few in the phase 1, suggesting that if these lead candidates fail, then we'll struggle in having to get new candidates into the pipeline. One of the challenges with TB research, vaccine research, is that the definitive protective antigens are not known. And in an earlier work in which Dr. Ernst was involved, they showed that T cells epitopes to the classical immunodominant antigens are hyperconserved, implying that human T cell recognition of these epitopes has little impact on survival and growth of MTB. So they followed up their initial observation by sequencing more strains, and they not only confirmed their initial observation, but also found that there are exceptions where they identified 7 antigens that show evidence of diversifying selection. For this talk, I'll focus on those that are highlighted in green. So the way we have been studying these antigens in the lab is we establish a household contact cohort in East Africa, in Kisumu, Western Kenya, and in Addis Ababa, Ethiopia, where index cases are identified. The households are screened by quantiferon, and then those who are HIV negative and consent to the study are enrolled, and we followed for 2 years. In addition, we have 60 distinct MTB antigens that are synthesized at overlapping peptides covering the entire length of the protein. So with this now, so we set out to test to ask the question whether do T cells that recognize novel antigens under diversifying evolutionary selection differ from T cells that recognize classical antigens. And the first hypothesis we wanted to test was whether human T cells with distinct MTB antigen specificities differ in their phenotype, function, maturation state, and trafficking potential. And this is important because we know no single T cell feature is sufficient to define protective immunity against MTB. The next hypothesis that we will test, and I will not show that data today because we are currently running those experiments, is whether T cell features correlate with and may be responsible for different MTB infection outcomes. And this is important because by identifying potential active TB progressors before their progression, we will reduce the overall cost of treatment and limit the rate of transmission of TB. So the first thing that we did was we measured interferon gamma response in whole blood to these 60 distinct TB antigens in our participants. And in this heat map, which is color-coded by red being low response and green high response, every column is an individual MTB antigen. Each row is an individual participant, and some of the antigens are indicated at the top of the heat map. What you can appreciate is that for most studied antigens, or the classical antigens like ESAT6, CFP10, and also PPE18, which is included in the M72 vaccine, is that there's a lot of green in those columns, meaning the high interferon gamma response. On the other hand, for novel antigens that show evolutionary selection, indicated by arrows, there's a lot of red in the meaning that they elicit very low interferon gamma response in whole blood. However, if you look deeper, you find that there are some cases where even within those novel antigens, there are individuals that make pretty high interferon gamma response. So there is variation across the population and within the individuals for each antigen. So with these results, we moved our assays to intracellular cytokine staining. This is after short stimulation with these antigens. And in these graphs, to orient you is that the dotted line is the separates individuals that do not make any response after subtraction of non-stimulated background. Every dot is an individual participant, and what you can appreciate is that for the novel antigens, IL-17 response magnitude is high compared in novel antigens compared to IL-17 classical antigens. Secondly, is that there are fewer individuals with no detectable response to IL-17 in the novel antigens compared to classical antigens. For interferon gamma, there is variation, but we don't see this distinction between the two classes of antigens. We did the same studies at 6 months, and here I'm just focusing on individuals that make detectable response. And what we show is that IL-17 response is higher magnitude compared to interferon gamma at both baseline and 6 months. We saw that first in our Kisumu cohort, and we made a similar observation when we analyzed our participants from Addis Ababa, Ethiopia. And this was very encouraging for us because it validated our initial findings. And we not see any difference between interferon gamma and IL-17 response to classical antigens. So as I said before, no single T-cell features are enough to define protection. We have also been looking at T-cell differentiation. And for this, if you look at the novel antigens shown here, we find that they are enriched for central memory T-cells compared to SEB that are mainly effector memory. When you look at IL-17 response to those similar antigens, then we find that most of them are central memory and effector memory. And additionally, that IL-17 response is enriched for effector memory compared to interferon gamma, and we don't see that for SEB. Another interesting observation we made here is that there are some individuals that have very high responding cells that express a naive phenotype, and this is not a typical response would expect, especially given that these stimulations are done for a very short time. So we are interested in pursuing that further to find what exactly how are naive cells involved in response to TB. Looking at literature, there are some studies that have actually reported that there are T cells with a stem cell-like phenotype or naive phenotype that make response to MTB antigens in humans. And in a mouse experiment, they showed that adaptive transfer of these naive-like cells offered protection. So we are interested in following this further in our cohort. So today I've shown you that CD4 T cells with distinct MTB antigen specificities have different functional properties. And we've also shown that individuals with undetectable levels of interferon gamma make other MTB specific cytokines. I've shown today only IL-17 responses. That novel antigens are enriched for IL-17 producing T cells, while classical antigens are skewed towards interferon gamma production. That for the novel antigens, CD4 effector memory T cells produce IL-17 more than interferon gamma, and additionally higher frequency of central memory CD4 T cells produce either IL-17 or interferon gamma compared to SEB. So we are currently testing the hypothesis that variation in T-cell responses may be responsible for differences in TB outcomes in humans, and we'll specifically focus on interferon gamma and IL-17 responses between the two classes of antigens in people who progress versus those who don't progress. With that, I would like to thank Dr. Ernst and the members of the Ernst team, our collaborators, and the funders who made this work possible. Thank you.
Thank you so much, Dr. Agongo, for an exciting presentation on T-cell responses. Next, we have Dr. Sarah Stanley, and immunometabolism and MTB infection.
I want to start by thanking the organizers for inviting me to present today at UCSF World TB Day. It's really an honor to be here. I'm going to begin my talk by telling you about one of the world's most prevalent mutations. About 40% of East Asians and over 500 million people worldwide carry a specific polymorphism in the gene ALDH2, which encodes aldehyde dehydrogenase. This polymorphism is a mutation which actually has a dominant negative function and represents a loss of function of this enzyme. Many of you are probably familiar with this polymorphism, as one clear consequence of carrying the ALDH2 polymorphism is an inability to effectively metabolize alcohol. The first step in the metabolism of ethanol after consumption is the conversion of ethanol to acetaldehyde by alcohol dehydrogenase. Acetaldehyde, and indeed aldehydes in general, are quite toxic due to their inherent reactivity. And when produced as a byproduct of metabolism, they need to be detoxified. Aldehyde dehydrogenase 2 is essential for detoxifying acetaldehyde by conversion to acetate. ALDH2 is also known to play a role in the detoxification of other small aldehydes produced by metabolism. But in the case of alcohol consumption, when an individual with a loss of function ALDH2 allele consumes ethanol, they're unable to detoxify the acetaldehyde. And this builds up, causing blood vessels to dilate, which results in the characteristic flush of alcohol flushing syndrome, which is associated with this polymorphism. Acetaldehyde is also more toxic than ethanol, and so there are other negative physiological effects. Acetaldehyde and other small aldehydes are also known carcinogens, and it's well documented that individuals with a loss of function mutation in ALDH2 are susceptible to various types of cancer. So a long-standing question has been, since we know that there are adverse effects on health of this mutation, what selective pressure has maintained this allele in the population throughout evolution? And what I'm going to tell you about today is a hypothesis that this mutation may actually be protective against TB and potentially other infectious diseases. So I first started thinking about this project with my collaborator, Heron Darwin, a professor at NYU, when she was on sabbatical here at UC Berkeley, visiting the lab of Russell Vance. And she pointed out this paper to us, which looked for the effect of ALDH2 polymorphisms on several diseases in human populations, including hepatitis, asthma, type 2 diabetes, and TB. So this was a group in Korea looking at a Korean population, and they found a statistically significant association between the ALDH2 mutation and only alcoholism, which is not surprising, but also TB, which was potentially more surprising. And what their data suggested was that people who have this ALDH2 mutation are perhaps protected against developing active pulmonary disease. And they attributed this in this paper, in the discussion, to potentially the fact that people with this polymorphism don't consume as much alcohol, they have a healthier lifestyle, and therefore may be less likely to develop active pulmonary disease. But Heron and I actually thought perhaps that this result, if true, may have something to do with ALDH2's role in detoxifying aldehydes. And we both had an interest in aldehyde, Heron from her work on understanding the responses of TB to nitric oxide, which is very important for control of infection, and me in my work of trying to understand how the metabolism of the macrophage contributes to its ability to kill TB. So the first thing we wanted to know is this you know, neither of us are epidemiologists. Is this really true? Is there really a less active TB in people with this polymorphism? So to get at this question, we collaborated with Sarah Dunstan at the University of Melbourne, who's a very talented epidemiologist and has been maintaining a cohort of TB patients in Vietnam for many years. And she's identified numerous interesting associations between the genetics of the patient and outcomes of TB infection. But what we asked her to do was to perform candidate gene analysis of ALDH2, looking at pulmonary TB patients versus population controls to see if ALDH2 had any significance. And what she found was that this loss of function ALDH2 polymorphism is associated also, again, with protection against active pulmonary TB with a p-value of 0.01. Interestingly, this association was driven by infection with the Beijing lineage strain of TB, which is highly prevalent in East Asia and less prevalent in different parts of the world. And this association was also statistically significant. So this made us feel more confident that this mutation may actually be associated with protection against pulmonary TB. And then if that's true, the next question is why? Is it because of lifestyle differences, or is it potentially because of ALDH2's role in detoxifying aldehydes? So the reason that we were particularly interested in a potential role in detoxifying aldehydes is because of ALDH2's known role in detoxifying aldehydes that are present at high levels during inflammation. When a macrophage is infected with TB or another bacteria, there's a very strong oxidative burst. Lots of reactive oxygen species are made that attack the bacteria and can kill the bacteria. However, these reactive species are not selective, and so there's a lot of collateral damage to the host. And one of the things that happens is that host lipids also get oxidized. And because polyunsaturated lipids are really common in host cells, the end product of the lipid peroxidation that occurs is the production of these two aldehydes, malondialdehyde and 4-hydroxynonenal. And it's been shown that these aldehydes can build up to levels of up to 5 or 10 millimolar in areas of inflammation in vivo. And ALDH2 is known to detoxify 4-H&E. So we hypothesized perhaps in a patient that lacks ALDH2, when the cell responds to infection with an oxidative burst, you'll see more 4-H&E, and perhaps this aldehyde may be toxic to the bacterium. One piece of data that is consistent with this hypothesis is that actually when we look at expression of ALDH2 in macrophages, it is expressed in macrophages. But the expression goes down when you infect with TB, and even more when you add interferon gamma, suggesting that macrophages are programmed to decrease the detoxification of this aldehyde just at the time when more of this aldehyde is being produced. So I'm going to show you just a little bit of data, given the time constraints that we have today, that support the hypothesis that maybe ALDH2 is playing this role in TB infection. So the first question is, are these aldehydes actually toxic to TB? And Heron actually performed this experiment herself in her lab at NYU. She exposed bacteria in culture to either 4-hydroxynonenal or to malondialdehyde. And indeed, she sees that these aldehydes are able to kill TB in a dose-dependent manner. And it's happening at concentrations that are physiologically relevant. What's even maybe more interesting is that when she combines these aldehyde with nitric oxide, which is also produced in macrophages and is already known to be very important for controlling infection with TB, that we see this synergistic killing. And indeed, with 4-H&E, we see this almost complete sterilization of the culture at physiologically relevant concentrations of these molecules. Okay, so now we know that these aldehydes have the potential to kill TB. The next question then is the reason that people who lack ALDH2 may be protected from TB because they're getting a buildup of these aldehydes. So that's a really difficult question to answer in humans. And so it's an easy question, or easier question to answer in mice. And so we turned to the mouse model of TB. And together with Russell Vance, who actually made these mice for us, we made mice that recapitulate the human mutation. So we actually made two strains. One of them is a knock-in for the mutant allele from humans. The other is just a functional knockout. We've only had a chance to infect the knockout mice so far. But what we see is that when we infect these mice with TB, the ALDH2 deficient mice are indeed protected against TB infection, as measured by bacterial burdens in the lungs at 28 days post-infection. And what you see here on the right is data compiled from 3 experiments where we see, on average, about a log less bacteria in the lungs of these ALDH2 knockout mice compared to the controls. So I have just one last piece of data that I want to tell you about because I think it's very exciting. And that is that there is a drug that targets ALDH2 and inhibits it. It's called disulfiram, or antabuse, and it's given to alcoholics to mimic the effect of the ALDH2 mutation and make them feel sick, when alcohol is consumed. Several years ago, a group in Japan actually looked at disulfiram, and they treated mice that were infected with TB with this drug, and they found that it was actually fairly efficacious in clearing the bacteria from the lung. And what you're seeing here are the vehicle controls compared with disulfiram treatment and also rifampicin treatment. And so you can see in the way this experiment is done here, the disulfiram is about as effective as rifampicin. And they attributed this to a potential direct antimicrobial activity of disulfiram, but we would hypothesize that potentially there may be a synergistic effect between its ability to inhibit bacterial growth and also its ability to inhibit ALDH2, leading to the production of more reactive aldehydes. So in summary, what I told you today is that humans with loss of function mutations in ALDH2 are protected from TB infection. We can recapitulate this in mice, meaning it's unlikely to be environmental factors that are responsible for this observation, and that TB is sensitive to 4-H&E, an aldehyde that we know is detoxified by ALDH2, particularly in combination with nitric oxide. So I think there's a lot more interesting questions and answers. Does disulfiram have ALDH2 dependent efficacy in TB? We can test this in the mouse model. Do these phenotypes that we're seeing in mice result from increased 4-H&E production or maybe other aldehydes? Are other bacteria killed by 4-H&E? And finally, can disulfiram be repurposed for treating TB or other infections in humans? So I'm just going to leave you with our hypothesis, which is that the host harnesses multiple toxic aldehydes to help control infection with intracellular bacterial pathogens. And I'll end with my acknowledgments. So my wonderful collaborator and friend, Heron Darwin at NYU, and her graduate student, Gina Limon. Sam Berry in my lab has done all of the animal work with the ALDH2 mice that I showed you today. Russell Vance generated these mice for us in his lab. I also have a really wonderful project on a different aldehyde I didn't have time to talk to you about today with Dan Portnoy here at UC Berkeley with our shared graduate student, Andrea Anaya Sanchez. And then finally, I'd like to thank Sarah and her postdoc Shirley at the University of Melbourne, as well as the funding. And thank you very much for your attention, and I'm looking forward to the question and answer session.
Thank you so much, Dr. Stanley, for a very interesting talk and lots to think about with regards to alcohol consumption and TB. And next we have Dr. Matt Kutis on tissue engineering.
Well, thank you to the organizers for the invitation to speak today. My name is Matthew Kutis, and I'm an assistant professor in the Department of Cell and Tissue Biology here at UCSF. Today, I'm excited to share our early efforts in collaboration with the Ernst Lab to apply tissue engineering principles in order to develop a biomimetic model of human TB pathogenesis, specifically focusing on the granuloma lesion. We all know that granulomas are the three-dimensional tissue lesions where the cellular and molecular interactions that determine the outcome of infection by Mycobacterium tuberculosis occur. That is, whether innate and adaptive host immune responses contain and eliminate the bacteria or whether it persists to cause chronic infection and transmission. Now, as tissue engineers, we were very struck by how stereotyped the three-dimensional tissue architecture of granuloma are, so much so that cartoon descriptions can be drawn of the relative cell positioning within these structures. We know that within the granuloma core, Mycobacterium tuberculosis typically enters a latent phase characterized by a non-proliferative phenotype within infected mononuclear phagocytes, which are primarily macrophages, and these infected cells are walled off by non-infected macrophages and giant cells. At the very perimeter of the tissue structure are non-infected lymphocytes, your T cells and B cells, and missing from this figure are fibroblasts, which lay down fibrous ECM proteins in order to create a physical wall between this lesion and the surrounding tissue, leading to a latent infection that is effectively contained. There's also increased microvascular density around granuloma structures, and these microvessels have abnormal structure and function. And altogether, the presence of this increased vasculature is not only necessary for immune cell homing, but the overall growth of the granuloma tissue structure. A second point that really drew our attention as tissue engineers is that within the same individual, instances of simultaneous TB granuloma progression and regression can occur. Here we can see a lung section from a TB surgical resection study. And within this subject, we can observe discrete granuloma with distinct lymphocytic cuffs and extensive collagen deposition characteristic of latent infection, as well as those with neutrophil-rich necrotic cores, characteristic of granuloma that failed to contain the bacterium. Now, altogether, this suggests that there is order to the assembly of these structures, and that granuloma phenotype and outcome may be determined by local host pathogen interactions rather than the overall systemic immune response of the host. But due to the difficulty to, again, access MTB infected tissue, the principles of this assembly and the rules of protection versus permission or dissemination remain poorly understood and really are largely based on studies such as this one. So therefore, we believe that there's an outstanding need for new human model systems that provide insight into the fundamental cellular and environmental control systems that govern the assembly of TB granulomas. So how might we begin thinking about constructing such a model? When we think about state-of-the-art models of human TB or human tissue development and pathogenesis, organoids immediately come to mind. Organoids are three-dimensional multicellular structures that mimic the organization and function of their target tissues, and really have revolutionized our understanding of human organ development, regeneration, and pathogenesis. Shown here are human lung organoids, and recently they've been instrumental in identifying mechanisms of viral entry for SARS-CoV-2. However, human lung organoids in their current stage have little value in human tuberculosis research. And this is because TB infection is caused by inhalation of MTB. It's phagocytosis by an innate immune cell within the airway, usually an alveolar lung macrophage, which ultimately migrates into the interstitial space to form a fused mass of immune cells, which the Ernst lab and others have demonstrated to be derived from the circulation. So how can we use those principles to develop a new model? In my lab, we like to take an iterative approach to the bottom-up assembly of functional human tissues in vitro. And with this approach, time and time again, biology has shown us that when provided the right boundary conditions, cells possess the inherent capacity to self-organize in vitro and ultimately reveal in vivo morphogenic principles. And we believe that such an approach might be useful for generating new testable hypotheses for the processes that underlie human TB granuloma pathogenesis. Therefore, the ultimate goal of this study is to develop a vascularized human TB biomimetic in order to examine how local host factors dictate the 3D architecture of the tissue, specific cellular phenotypes, and ultimately the outcome of TB infection. So how do we begin? To start, we've borrowed two principles from tissue engineering as it's been applied to cancer modeling. The first, the ability of specific cells to self-assemble into three-dimensional aggregates when suspended in non-adherent microwells. And these approaches, again, have been instrumental in deriving fundamental behavioral insights into human solid tumors. That is, the role of hypoxia and necrotic core of the tumor, as well as interactions with the marginal tumor cells with the surrounding extracellular matrix. The second principle we adopted is the introduction of tissue-specific extracellular matrix, which can be generated by using primary human fibroblasts. And so in order to generate extracellular matrix in vitro that captures organotypic signatures inherent to the tissue of origin, we're able to take primary fibroblasts from the lung stroma, which will generate a large amount of matrix ex vivo, which we can then harvest and introduce into our downstream assays. So with these two approaches in hand, we set out to establish a protocol that might allow us to assemble a granuloma-like aggregate. And so to generate a human granuloma biomimetic, as we are calling them, Beth Chang and Leica Mayo, two students working on this project, have pioneered a protocol in which peripheral blood mononuclear cells are plated overnight to isolate the adherent fraction, the monocytes, which then differentiate into macrophages. These adherent cells are then infected here with Mycobacterium bovis, BCG. After a period of infection, the extracellular bacteria is killed, and the infected adherent cells are harvested and mixed into these non-adherent wells I was referring to with additional PBMC fractions. And by doing so, we see something remarkable. These cells initially assemble into aggregates in which the bacterium appears to be contained within the spheroid center. And additionally, over time, these structures will progressively grow and organize, suggesting that there's long-term viability of the mononuclear phagocytes and lymphocytes that are contained within. And so while we're still very early in this project, we've been able to make a number of interesting qualitative observations. The first is that this model is reproducible across multiple PBMC donors. And interestingly, by varying the specific ratio of initially infected cells to added PBMCs, we can predict and control the aggregate size. The second interesting observation is that we've seen distinct compaction phenotypes and apparent bacterial containment that associates with each. And this appears to be dependent on the specific amounts of, again, specific mononuclear phagocytes and lymphocytes that are added at various stages of the protocol. So again, while we're at the very early stages of applying this model and characterizing these phenotypes, we are very interested in using this model to gain high-resolution insights into the cellular organization and behavior within these granuloma-like aggregates. And so to do that, we are currently optimizing immunofluorescent approaches in conjunction with super-resolution confocal microscopy to quantitatively characterize the organization within these human biomimetic granulomas. Here we're looking at a medial slice of a 3D hole-mounted granuloma-like aggregate, and we can begin to appreciate the apparent segregation of specific cell types. By using image segmentation approaches, we can quantitate and observe that CD3 positive lymphocytes seem to be restricted to the tissue periphery, whereas CD14 monocytes are found throughout and most closely overlap with the bacterium in the tissue center. Now, there are critical cell types missing here, and we are working to stain and build quantitative maps, such as those that are shown on the right here, across multiple HBGs in order to build, again, a roadmap to assembly of these structures. However, one thing we did notice is that even in the absence of added extracellular derived matrix that I was referring to before, we can observe a dense extracellular matrix is being produced within these tissues, and this is likely critical for their assembly. And so we're quite interested in the origin of this extracellular matrix assembly and its role in influencing the differentiation and function of other cell types within this structure. And so I hope I was able to convince you that we've established what appears to be a tractable 3D model of human granuloma-like aggregates, and we intend to employ to understand critical regulatory elements of these structures. To do so, we're actively engaged in 3 areas. One, looking whether BHG is infected with virulent MTB and a rationally attenuated strain of MTB in order to identify spatial relationships and specific interactions that might associate with progression or elimination of the bacteria. The second is we hope to introduce human lung fibroblasts and extracellular matrix in order to see if we can recapitulate the fibrotic cup observed in humans. And ultimately, we hope to benchmark these features and molecular signatures in human and non-human primate TB granulomas. Now, in these last few slides, I'll explain our planned approach to vascularize these structures. And so our plan is to leverage existing technologies that allow us to generate perfused human lung microvascular networks within a microfluidic device and specifically introduce tumors or other cellular aggregates in the center of the network. And the way this works is we structure 2 endothelialized channels within 3D lung extracellular matrix hydrogels that also contain single lung endothelial cells and fibroblasts. Progressively, over about 3 days, these cells have the remarkable ability to self-assemble into a perfusible microvascular network. These capillary-like vessels retain signatures and functions reminiscent of those in vivo, such as tight barrier function, and support the perfusion of monocytes, here shown in red. Further, we can then take these preformed human tumor aggregates and embed them within these networks and observe functional integration and crosstalk with the vasculature. And so all together in parallel efforts, we are now working to establish pipelines to integrate our HBGs into preformed vascular networks in the BSL-3 setting. Once in hand, we hope to assess bidirectional morphogenic changes in each tissue and identify key signaling players. And overall, our ultimate goal is to integrate circulating monocytes and lymphocytes to more accurately capture the initial seeding and growth of granuloma by by immune cell homing and an egress at the granuloma site. And so with that, I would like to thank you for your attention. I would like to acknowledge Lakin Mayo and Beth Chang, who is from the Ernst Lab, who have led this work, as well as the funding support from the UCSF Center for Tuberculosis TB Ramp Scholar Program.
Thank you so much, Dr. Kutis, for a very interesting presentation and beautiful images. I believe Professor Payam Nahid will make an announcement and then we'll get back to the question and answer period.
Oh, no, sorry, Sarah, carry on with the question and answer. Okay. I just, to close the session.
All right, my apologies.
Thanks.
All right, so we have a question from Oshioma from UC Davis. This is for Dr. Paulo Gongo. For stimulation experiments, how do you determine the concentration of MTB and duration of MTB exposure to the cells?
Thank you, Oshioma, for your question. For the concentration, I think you need to know the nature of your stimulatory antigen, whether it is whole protein or peptide or the way it was prepared. So in that way, you know how much to put, considering that the antigen presentations are needed. And it's also important that you empirically test before you start running examples. You test different conditions, and that is important because at least we have the benefit of having access to studies that have used similar antigens, either by the way they are made. So you need to approach those, do the literature to give you a rough idea, know the nature of your protein, and then importantly empirically test so that you get the right concentrations to use and how long you need to stimulate.
All right, thank you, Paul. And then a question from Gustavo. So out of curiosity, metronidazole is an antibiotic with reported disulfiram-like reaction. I'm curious if newer versions of the antibiotic that we are using in TB, like protomanid and delamanid, might have a disulfiram-like effect, and whether this translates to what you are observing in your lab. This question for Dr. Stanley.
Yeah, thank you so much for that question. That's a great question. You know, the short answer is we don't know, but I think that now that we have a tool now to test this question, which is we can look at the efficacy of drugs in a wild type mouse versus a mouse that's missing ALDH2, and if there's a difference, we could maybe conclude that these drugs may be having dual bug and host targeting activity, which I think would be really exciting.
Thank you. And I have a question actually for Dr. Koutis, and I'm wondering to what extent pluripotent stem cells can be used for inclusion in these granuloma models that you're using, and whether we can use, for example, CRISPR-Cas9 gene editing and you know, change the fate of the fibroblasts that are involved in the granulomas.
Yeah, I think that's a really great point. I think, you know, those genomic tools have been applied to macrophages, and it'd be really interesting to see if we could do sort of genome-wide screens to see which specific genes are important for the formation of these structures. When we talk about specific components from the PBMC fractions, the use of iPSCs could be really beneficial in introducing parenchymal lung tissue into these models as well. So I think there's a lot of room to explore those sort of parameters, and we're really just excited to get these models off the ground.
Very exciting work. So with that, I believe that concludes the Q&A session. Thank you for an amazing basic and translational science talk. This just gives you a flavor of all the activities that are happening in the Bay Area. And if you're looking for labs, there's 3 labs here that you can join. And with that, I wanted to thank everyone for an amazing World TB Day and hand it over to Professor Payam Nahid for closing remarks.
I wanted to now thank all of our speakers and moderators for an outstanding 2022 UCSF World TB Day Symposium. Our event today was organized by a terrific planning committee who spent months of preparatory work to develop the agenda you had today. And specifically, I want to shout out to Sarah Solomon, Chris Berger, Devin Jagannath, Gustavo Velasquez, who are really key leads on the planning committee with support from many others. And special thanks to Alicia Couchman, Kelly Masoki, Sarah Hutchinson, Barbara Alonso, and the Curry team for all the support and coordination that you provided. I thank Representative Dr. Ami Bera, for his remarks and continued championing of programmatic and research investments needed to accelerate global TB elimination efforts. My thanks to Mark Lipman and our friends in London for joining forces with us today. It's always a pleasure. And our sincerest and special thanks to our keynote panel members, Humeza Tisli, Gloria Moses, Ria Lobo, for sharing their intimate experiences with TB and for bravely challenging the scientific community, all of us, to do more to improve care of patients and also in holding our governments and investments accountable. I hope you have enjoyed the symposium, and I thank you for attending. Take care.